that at the end of the whole thing, only your name will be glorified and our intention realized to the glory of your holy name.
Yes.
In Jesus' mighty name we have prayed. Amen. Name of the Father, name of the Father, and the Son, and the Holy Spirit.
The Son and the Holy Spirit. Amen. Thank you very much. Thank you very much. At this point, I'm going to invite the National President of the Medical Women's Association of Nigeria, Dr. Mnte Oseji, to give her opening.
Amen. Can you hear me? Hello? Hello?
Yes, we can hear you.
We can hear you.
Hello?
We can hear you.
Hello?
We can hear you. We can hear
Please,
you.
can you hear me?
Yes.
Okay.
We can hear you.
Sorry. Okay, thanks so much.
I
Sorry,
hear you.
I have to change. Oliver, please open the curtain. Our national coordinator. What is the issue? I hope it's not from my own end.
So sorry, I was still muted. Hello, I can hear you all.
Okay.
I'm waiting for our national president to give her welcome remarks, please.
Okay, I'm ready to do that. Can I go ahead?
All right. Yes, ma'am. Please, ma'am. Thank you.
All right. I'm distracted by all these people that are to be admitted.
Admitted. Okay.
So many people
Yes,
waiting.
we are continuing from here.
Okay.
Yes.
Good morning, distinguished ladies and gentlemen. I wish to make the above remarks on this occasion of the Continuous Medical Education Program on Maternal Neonatal Tetanus Elimination, Mnte. Today, Saturday, 30th January 2021. I bring you very sincere and warm greetings from the National Secretariat of the Medical Women's Association of Nigeria, domiciled in Asaba, Delta State, with its permanent headquarters in Abuja, Federal Capital Territory. As of June 2017, Mnte, that is maternal neonatal tetanus, remained a major public health problem in 16 countries, namely Afghanistan, Angola, Central African Republic, Chad, Congo, DR, Guinea, Kenya, Mali, Nigeria, Pakistan, Papua New Guinea, Philippines, Somalia, Sudan, South Sudan, and Yemen. By 2019, July, 12 countries have still not reached Mnte status, Nigeria inclusive. M1, Medical Women's Association of Nigeria, can make a significant case through awareness creation and supportive supervision. Tetanus vaccination coverage is measurable, so it is possible to determine if we are making impact. Reports reaching us from the National Primary Healthcare Development Agency reveal that neonatal tetanus validated cases for the period from January to July 2020 were Anambra 6, Bayelsa State 5, Cross River State 1, Delta State 1, Enugu State 1, Imo State 1, Katsina State 4, Kebbi State 6, Kogi State 1, Ondo State 2, Oyo State 2, Zamfara State 5. M1 recently raised alarm over the relatively high number of cases of neonatal tetanus reported in the adopted health facility in Zamfara State in the year 2020, a total of 12 cases in the space of 8 months. This was brought to the attention of the Federal Ministry of Health and other stakeholders like the Primary Health Care Development Agency, National. The association decided to organize a continuous medical education CME program today on MNTE to guide stakeholders in the implementation of efforts to achieve MNTE. It also intends to donate chlorhexidine gel for umbilical cord care to mothers from LGAs with high rates of neonatal tetanus in Zamfara State. We have been ready for this activity for quite some time. All we are waiting for is the supplier of chlorhexidine. So if anybody who has the contact, we have asked a number of people, we are yet to get a supplier of genuine chlorhexidine. And then we also need the details of the LGAs with high rates. We're expecting them from our contacts in Zamfara State. The efforts to eliminate MNT are simple and cost-effective. Mobilize women of childbearing age to be immunized with 5 doses of tetanus vaccination. We already have a lot of women of childbearing age in our secondary schools, so we can start with that. Ensure hygienic practices at birth. Ensure clean cord care. At this juncture, I wish to appreciate Dr. Lillian Ekwem, Dr. Basi Okosen, Dr. Samuel Oyeni for all their support in amplifying M1's voice on the matter of MNTE. Many thanks also go to all presenters at today's program, Professor Kolo, Dr. Chima, Dr. Omwemo, Dr. Ekwem, and my humble self for sacrificing the time to facilitate this program. To all my M1 angels, I pray for God's special reward for all your labor of love, particularly in this biennium. Thank you all for attending this program, and God bless you. I am Dr. Mininim Oseji, M1 National President.
Thank you very much, ma. I believe we were all spiked. Our interest has been spiked the more by her message. We see where we are as a country, and we need to improve. And we're not going to get people to come and do it for us. We're going to do it by ourselves. So we're keeping to time. And I'm going to call up our first lecturer, Dr. Maureen Kawulu. Dr. Maureen is going to. Okay. Yes.
She's muted.
All right. She should be able to unmute. Okay. She's going to call that name for us by herself. That's a new name, but we have to get used to it. So you're all welcome. Dr. Maureen JP. Okay. JP,
yeah.
Fellow of the West African College of Surgeons, FMCOG, is a consultant obstetrician and gynecologist with the National Hospital Abuja FCT, and has worked meritoriously in the National Hospital Abuja for the past 18 years. She's an alumnus of the University of Calabar, Cross River State. She's in charge of the Gyne Oncology Unit of the National Hospital Abuja and has done many publications, especially in gyne oncology and women's well-being. She's currently writing a paper on domestic violence. She's a reviewer of prominent journals like British Medical Journal, Journal of Pharmaceutical Research International. She's also a supervisor of the National Open University of Nigeria from 2015 to date. She supervises undergraduate and postgraduate theses of the Open University of Nigeria. She's a fellow of the West African College of Surgeons and National Postgraduate Medical College of Nigeria. She's a member of many professional bodies and holds different executive positions. She's a member of the International Gynecological Cancer Society, the European Society of Gynecological Oncology, Society of Gynecology and Obstetrics of Nigeria, Association of West African Societies of Obstetrics and Gynecology, Lifestyle Medicine Practitioner Association of Nigeria, Medical Women's Association of Nigeria, and the Nigerian Medical Association. She is presently the Vice Chairman, National Medical Association, Nigerian Medical Association, FCT chapter. She is the Secretary of the Nigerian Medical Women's Association, FCT chapter. She's a Treasurer, Society of SOGON, that's SOGON, Society of Obstetrics and Gynecology of Nigeria, North Central Sector, and also a council member of SOGON. She's also the Treasurer of the Association of West African Society of Obstetricians and Gynecology. She's married with 4 children. So, Dr. Maureen Umwemo Umeakulu, you are welcome.
Thanks so much.
We will learn it. We will know it.
You must learn it.
We must learn it.
Thanks so much, my
over
sister.
to you, ma'am. Thank you. 45 minutes.
Thank you.
All right.
Okay. Good morning, my elders and lovely colleagues. It's so nice to be with you this morning, and we are discussing a very intelligent topic, an important topic, maternal and neonatal tetanus. So this morning I'm going to look at the title, Epidemiology of Maternal and Neonatal Tetanus, including World Health Organization overview of maternal and neonatal tetanus, and the importance of elimination. And I'm also going to look at presentation and management of maternal tetanus. Though it's the long title, but in summary, it's just to look at the epidemiology, look at the World Health Maternal and Neonatal Tetanus Elimination Initiative, and also look at maternal tetanus in terms of its presentation and management. Our national coordinator has done so much in my introducing me, so I don't need to introduce myself again. And we are going to follow this outline. Now, as a way of introduction, maternal and neonatal tetanus has been among the most common life-threatening consequences of an unclean deliveries and umbilical cord care practices. I should just open with these 2 important things, the unclean deliveries and umbilical cord care practices, because if we can handle the 2, we can handle maternal and neonatal tetanus. And is an indication of inequality in access of immunization and other maternal and neonatal and child health services. When tetanus develop, mortality rates are extremely high, especially when appropriate medical care is not available, as is often the case in low-income countries. You know, once we talk of infective things, or almost every other thing is developing countries, low-income countries. I wonder the day will be lifted higher and will be off that. And maternal and neonatal tetanus is still a substantial but preventable cause of mortality in many developing countries. As our president said previously, that maternal and neonatal tetanus elimination initiative launched by World Health Organization and its partners has made substantial progress in eliminating maternal and neonatal tetanus. But we still have so much to do, because even the remaining 12 countries, our own dear country, Nigeria, is still inclusive. So we must make a sustained emphasis on improvement of vaccination coverage, birth hygiene, and surveillance, with specific approaches in high-risk areas. High-risk areas we are talking about, you know, is developing countries, with Nigeria inclusive. As a way of etiology, and also pathophysiology, tetanus, we know, is an acute, often fatal disease caused by an exotoxin produced by a bacterium, Clostridium tetani. Clostridium tetani is an obligate anaerobic, motile, gram-positive bacillus. It is non-encapsulated and forms spores that are resistant to heat, desiccation, and disinfectants. Because of this quality I just mentioned, it's so difficult to eliminate tetanus toxoid. But while we are moving on, we'll know what is really our target when we mention elimination, because the spore is all over and is resistant to heat, desiccation, and disinfectants. To germinate, the spores require specific anaerobic conditions, such as wound with low oxidation and reduction potentials. That is a wound, a devitalized tissue, foreign body, active infection, septic wounds. So for it to germinate, it needs this anaerobic condition for it to survive. So under these conditions, upon germination, they may release their toxins. Infection by Clostridium tetani results in a benign appearance at the portal of entry. The portal of entry might not be specific. It may be devoid of inflammation because the tetani doesn't have the capacity to elicit inflammation. So the wound might even go unnoticed. But once the organism is inside, it starts producing infection. The wound can only become septic when there is a superimposed bacteria in further bacterial infections. If not, the wound may just look benign and unsuspicious. Meanwhile, the infection is already in progress. Now, when proper anaerobic conditions are present, the spores germinate and produce the following two toxins. The first is tetanolysin. Tetanolysin is a hemolysin with no recognized pathology activity, even though it's one of the toxins it produces, but the pathologists are yet to pin any of its symptoms to this particular toxin. But the main one is the tetanospermine. This is the real toxic effect of tetanus organism. It is the one that produces the clinical manifestation of tetanus. And it has been said to be the most potent toxins known. As little as 12.5 nanogram per kg per body weight can produce its lethal dose. So it's one of, if not the most potent toxins ever known. Now, still on pathophysiology, how does it act? The tetanus toxin enters the neuromuscular system. It enters the nervous system at the neuromuscular junction. The toxin therefore inhibits the presynaptic interneurons, resulting in this inhibition of motor neuron discharge. In fact, that is a summary of the pathophysiology and manifestation of tetanus toxoid. Because in the neuromuscular junction, there is a balance between the presynaptic, which is excitatory, and the post, which is inhibitory. So by the time the inhibitory is affected, there will be uncontrolled manifestation of the excitatory stage. I think I have a diagram to explain this. As I said previously, you can see the release of the tetanospermine. The tetanolysin, we don't know the pathological effect, but the main toxin is the tetanospermine. It releases into the neuromuscular junction, the excitatory transmitter, and the inhibitory. So the toxins bind to the inhibitory transmitters. It binds to the inhibitory transmitter, thereby blocking it. And once those neurotransmitters, that's the inhibitory, once they are blocked, the excitatory will have the field day. They are not under any control again. So anything, any stimulus, even as simple as a small noise, can trigger it to fire. Because there is no inhibitory aspect, persons tend to have continuous sustained spasm because of the inhibition of the inhibitory transmitters. I think, once the toxin, once it becomes fixed to the neurons, it cannot be neutralized with antitoxin. Why is this important? If you've seen a case of tetanus toxoid, it takes weeks for the person to recover because the neurons, once affected, once there is fixation of the toxins to the neurons, you cannot use antitoxins to neutralize it again. The only way is for the nerves to recover or for the neuromuscular junction to get back its function is by regeneration of a new nerve terminals and not the initially occupying neurons. That's why in tetanus patients, the spasm continues for a longer period. Some can last between 2 weeks to as long as 2 months or even more, because the system is waiting for a new nerve terminal to regenerate. Now, the Clostridium tetani is found everywhere, worldwide, in the soil, in inanimate objects, physics, dirty environments, name it, is everywhere. All it needs is unhygienic environment and it will be there. Because of that, it's predominantly in underdeveloped country, and we're not surprised because of our hygienic state. So it's here with us. And it's also common among farmers, rural areas where soil is cultivated, in warm climate during summer months. If you look at all these things, you notice that we in the warm area, we have everything, the unhygienic environment. We have a lot of our people in rural areas. Our climate is quite warm. So without comprehensive immunization and a clean environment, tetanus predominantly develops in neonates and young children, as well as our mothers. So this actually what I've explained before. So tetanus will develop once there is no protective circulatory antibodies. Once there is no antibodies, it will develop once it enters the system. And maternal tetanus infection follows abortion, miscarriages, unhygienic delivery practices. And if you look at these things critically, you notice that we can prevent it. We can actually eliminate tetanus toxoid. We can actually eliminate tetanus toxoid. Neonatal tetanus infection usually occurs through umbilical storm after delivery. You still see that it follows unhygienic environment, deliveries at home, untrained TBS. Then inadequate maternal vaccination and poor perinatal hygiene contribute to its occurrence. In 1988, because of a lot of morbidity and mortality associated with neonatal tetanus, as neonatal tetanus actually called the initial attention, the World Health Assembly passed a resolution to eliminate neonatal tetanus by the year 2000. However, 10 years later, by the year 1999, because there was still an upsurge of tetanus infection among 59 countries, World Health Organization felt it's quite pertinent to look into this initial neonatal elimination they did in 2000. And that came, the review was also with other partners like the UNICEF and UN Population Fund. So they came together and now decided to also incorporate the maternal aspect, because we cannot talk of neonatal tetanus without mentioning maternal tetanus. We cannot talk of neonatal tetanus without mentioning umbilical cord and delivery. So in 1999, they came together and launched the Maternal and Neonatal Tetanus Elimination Initiative. And it's mainly in Africa and Asia, where they got these 59 affected countries. And the deadline was now extended to 2005. Deadline to achieve elimination was moved to 2005, even later to 2015. So the maternal and neonatal tetanus elimination initiative to such low level that disease is no longer a major. Fortunately, in Nigeria, it's still a major public health problem. So when we mention elimination, what do we mean? We mean elimination. Elimination is defined as less than 1 case of neonatal tetanus per 1,000 live births in every district. Note that we're talking of 1 in 1,000. We are not talking of complete eradication. In polio and smallpox, we're talking of complete eradication. But in tetanus case, we're not talking of eradication, we are talking of elimination. Because tetanus spores are present in every environment worldwide and resistant to heat, even to disinfectant. So it will always be there. So we cannot talk of eradication. We can only mention elimination when we're able to achieve 1 case in 1,000 live births. Implementation of maternal and neonatal tetanus elimination initiatives has involved 3 main strategies. So in that 1999, the maternal and neonatal tetanus elimination came to be. Their main strategy were 3. 1 is immunization, 2 is birth hygiene, and 3 is surveillance. Now, when we mention maternal and neonatal tetanus elimination initiative uses 2 immunization programs. I'm happy that somebody will tell us extensively about immunization, but suffice it to say that in this program, their main immunization program were routine immunization of women during pregnancy and supplementary immunization activities. Supplementary immunization activities is immunizing women of reproductive age group, because the first one is the one we start during pregnancy, but the supplementary one is immunizing women of child in reproductive age group. You give them 3 immunization interval in order to boost their childhood, because believe that in our neonatal, in the childhood period, we complete our normal immunization program. So in teenage age and reproductive age group, they are top of, they are giving extra 3. That's what we refer as a supplementary immunization activities. Now, when World Health Organization launched Mnte initiative, their elimination strategies were as follows. They were hoping to achieve 80% coverage with more than 2 doses of tetanus toxoid containing vaccine among women of reproductive age through routine immunization of pregnant women and supplementary immunization activities in high-risk areas and districts. They also hope to achieve care of more than 70% of deliveries by a skilled birth attendant. So in a country, deliveries will be attended by skilled birth attendants in 70% of cases, which I don't think we're close to that in Nigeria. Then the third one is enhancing surveillance of neonatal tetanus cases. For any reported case is to follow it up and also to have a good record for surveillance and prevention. So how far with the Mnte initiative, how far have we come? Now, coverage with 2 doses of tetanus toxoid vaccine among women of reproductive age increased from 16% to 62% in 2000, then to 72% in 2018. So the initiative is actually achieving a lot. Globally, the percentage of the delivery assisted by national birth attendants, skilled birth attendants increased from 62% during 2000 to 2005 to 81% during 2013 to 2018, and estimated neonatal death decreased by 85%. There has also been a significant progress globally to eliminate maternal and neonatal tetanus. And approximately 75% of 59 priority countries, remember we said, that led to the launching of the initiative were validated to have achieved maternal and neonatal elimination by end of 2018. So by end of 2018, 75% of the 59 priority countries have also achieved their own elimination stage. And during that period, the tetanus death went down by 85%. Now in July 2019, 12 countries are still not reached maternal and neonatal tetanus elimination status. Unfortunately, Nigeria, we are still inclusive. So activities to achieve the goal are ongoing in those countries, with many likely to achieve it in the near future. Our CME is one of those activities we are trying to do, because we believe with this CME is not only to gain a CME point, but also for us to go back to our various centers and move against maternal and neonatal tetanus, so that we'll be among these countries, 12 countries, or be out. So we now have to look briefly into maternal tetanus. Maternal tetanus is defined as tetanus during pregnancy or within 6 weeks of the end of pregnancy. So tetanus during pregnancy or within 6 weeks of pregnancy, or miscarriage, abortion, and birth. Unfortunately, we don't have any formal reporting of maternal tetanus, because most of them that happens in the thick village that are unreported. The one following abortion, you know the abortion state in Nigeria, so they are not reported. So it's difficult to have a good statistic on maternal tetanus. Now, the elimination of maternal tetanus is assumed to occur when neonatal tetanus is eliminated. Even though we're talking about maternal tetanus, for one point of elimination, even in this country, is still based on the state of neonatal tetanus. In a study done in Northwest Nigeria, analysis of 8,220 live births at a hospital showed that 5.4% of maternal deaths were due to puerperal tetanus. So apart from the neonatal tetanus we're talking, maternal death is still a problem. And in this study, puerperal tetanus was incriminated. So we have to do a lot for us to eliminate maternal tetanus. The ongoing elimination of maternal and neonatal tetanus represents a continuing challenge. And we have to face it squarely. We have to stand and fight. We have to move forward, and we have to achieve our status. I have to talk briefly on abortion-related tetanus, because this is an area, even though underreported, there is claiming, especially our young adolescents, and is associated with higher mortality. They've carried a study and noticed that tetanus following septic abortion, the mortality is much higher to other related maternal tetanus. But we don't have any reliable data on post-abortion tetanus. As I've said, there is no documentation. It's not done in the hospital. It's done in a lot of dirty area, and you cannot really document what happens. And some of these girls, their parents don't even report. And there's this issue of blame game. So even at death, they're also not ready to report. You know, traditional abortion methods commonly involve high-risk practices, such as insertion of sticks, herbs, rooting. In another study done in Nigeria, it was noticed that 25% of Nigerian adolescents were reported as not having the normal serum concentration of anti-tetanus IgG. Among adolescents that have had at least one abortion. So you see that even the childhood tetanus vaccine we are taking, you know, is not for life. So at a point, it's being affected. And we also see, later I'll mention it, that in our country, because of high rate of malaria and HIV, our own immunity following tetanus vaccine is usually defective, though it's still a controversial area. So we quickly look at the clinical features. I've seen the incubation period is 7 to 10 days. The period of onset is between 24 to 72 hours. You know, the point of tetanus, maternal tetanus are on the internal entry site. The postpartum, post-abortal, intramuscular are associated with high mortality, as I've previously mentioned. Now, in tetanus, what we usually have is that of what? Spasm, hypertonicity of skeletal muscles. And in most cases, it is a generalized kind of spasm. Now, in this case, patients sometimes remember these injuries, though it goes unnoticed, as I said initially, in some patients, the early stage is difficulty in swallowing because there is already a subtle spasm of the next thing you notice is a tremors, what we call rupture. That's among the earliest one. And some people, it might be in just a localized kind of tetanus. So a limb might be the only one going into spasm. Then gradually it moves from the neck to the whole body. There is also associated restlessness, neck rigidity. Then the muscle rigidity will soon move around the whole body being affected, and it takes over 24 to 48 hours for the extension muscles of the limb. That's why you always notice that pronounced extension in tetanus patient. Now, because of the sustained contraction of the facial muscle, it produces a snarling green expression we call rhesus sarcoidonicus. You know, some people refer this as a wicked smile. You notice a smile on the patient's face, but the patient is not smiling. The patient is simply in pains. Also, when the respiratory muscles are affected, we have respiratory difficulties. Then when there is this pronounced extension of the whole muscle, we have what? The opisthotonics that we know of tetanus. Then when we have, in severe cases, autonomic nervous system dysfunction may also occur. By then you start having tachycardia, bradycardia, and arrhythmias. This is a summary of just the presentation I've given. It starts from the jaw to the neck, then moves to difficulty swallowing, muscle rigidity, and pronounced spasm. This is the rhesus sarcoidonicus in tetanus patient. You have this unusual, you think the patient is smiling, but he's not smiling. In fact, he's having very wicked smile because it's painful. The opisthotonics. The opisthotonics that I mentioned about, you will see the pronounced flexion of the muscle. This sometimes is associated with spinal fracture. It's a very dangerous symptom once it starts presenting. Unfortunately, you know, because our body is mostly male pictures, I could pick in order to, you know, to show the real features of what we are talking about, the pronounced neck stiffness and retraction. And you know the painful thing, with all these painful pictures, the individual is conscious throughout the illness and the contraction cannot stop. The sensorium is intact, so the patient feels severe pain, conscious, and it continues. Sometimes it can record tendon rupture and acute respiratory failure. Now there is a scale for measurement of severity of the disease, and you give 1 for each point. When the incubation period is less than 7 days, you give 1. When the period of onset is less than 48 hours, you give 1. By incubation period, we all know from the point of injury, the point of the first symptom manifesting, while the period of onset is from the point of first symptom manifesting to the spasm. Then we also thought of the source of the injury, whether it's a bone, is a compound fracture, is a septic abortion, is it in an adult, that an adult manifesting with tetanus toxoid, we give it extra 1 mark. Is it a generalized tetanus? What is the temperature? Is it above 40 or is tachycardia above 150? Then after the scoring, this, I think you can see my slide. Hello?
Yes, we can.
Okay. So this is the scoring. When the score is 1, is mild. The prognosis is, mortality is less than 10%. When it's 2 to 3, moderate. Mortality is less than 20%. Is 10 to 20. 4 is severe. Mortality 20 to 40. 5 and 6, very severe. Mortality is greater than 50. Okay. So the diagnosis, tetanus diagnosis is clinical. Is when you see tetanus manifestation, in most cases, you don't need to do any investigation, though you can still caution using oxygen-reduced blood agar or meat bath, or you can assay or use PCR detection. But in all this, it's usually not available and it should not delay treatment. So the mainstay is a clinical manifestation. Now, in the management of maternal and neonatal tetanus, our main target is the toxin, to neutralize the toxins so that you stop the issue of binding to more and more inhibitory neurons in the neuromuscular junction, then to eliminate the bacteria, which is the source of the toxin, the symptomatic control, and the supportive care. Under management, you give antibiotics, and the main antibiotics here is intravenous penicillin and metronidazole. Many studies have shown that that's the mainstay of treatment in eradication of the bacteria in tetanus toxoid. Then in parenteral antitoxin, you give equine-derived anti-tetanus serum, or you give human tetanus immunoglobulin. Human tetanus immunoglobulin in American is approved one, but the issue here is what? Availability. But studies have shown that either can also be quite effective. Now you can also give intrathecal antitoxin. Intrathecal antitoxin is injecting into the spinal cord. And studies have shown that this also improves survival. They've compared with or without, and it shows that it improves survival in most cases. Then in some, especially in developing countries, we use a lot to control spasm because we know ventilatory facilities are not always available. We use phenobarbital, chlorpromazine, intravenous diazepam, paraldehyde. Then in severe spasm, it has shown that it's better for them to be ventilated. It rests their body and takes over respiration for them. Now, magnesium sulfate usage is really another area authors are looking, researchers and scientists are looking into, but the evidence is still conflicting. Some said good, it improved prognosis, some said it doesn't, there is no effect. So it's still a very conflicting but interesting area in the management of tetanus. All wounds should be clean. As we are saying, remember that for it to grow, it needs anaerobic environment. So we need to deprive the wound, to deprive it of anaerobic state so that the wound will be well oxygenated, and that will help in the management of the tetanus. So we'll talk of the prognosis. Mortality associated with maternal and neonatal tetanus is quite high. Even adults is still as high as 52%. One of our facilitators will tell us about neonatal tetanus because in some areas it can go as high as 100% in neonates. Now the prognosis depends on the incubation period, the time of inoculation to symptom, as I said when we're grading, and the time of manifestation from symptom to the time of manifestation of the first spasm. Now, data is still poor in making prognosis because documentation, you know that it is not a problem of developed country. Once you have any condition that is not a problem of developed country, you will notice that research and data there will be a problem because we're not good in documenting, and our researches are mostly still at embryonic stage. But in a study in Tanzania, 8.6% of survivors were discharged with permanent disability, such as persistent vegetative state, limb amputations, and gait abnormality. Other long-term sequelae include persistent rigidity and memory loss. But there are things that we know as a statement, as well as far as tetanus toxoid infection is implicated, the tetanus infection, that the shorter the interval indicates more severe tetanus. So you get a shorter incubation period or a shorter onset period, it's likely to end with a poor prognosis. Patients usually survive tetanus and return to their pre-disease state, even though there's some area, there's some few we heal with some stigmata of the disease, but most tend to recover fully. And recovery is slow and usually occur over 2 to 4 months. Remember what I said? And once there is already binding of the toxins to the neurons, you cannot remove it. You must wait for a new neuronal terminal to germinate. And also some patients might remain hypotonic. After recovery, they move from hypertonic to hypotonic state. Clinical tetanus does not produce a state of immunity. That's very important one we have to mention. Patients who survive the disease require active immunization. So there is nothing like, I've had it before, I will not have it. No, it doesn't give a permanent immunity. And I previously said that another problem is issue of HIV and malaria in our environment. There are a lot of studies still showing that it affected. By the time they assess the cord blood, they notice that the level is not the required level. So it's likely that HIV with us and malaria with us is also a problem in the control of this tetanus toxoid. So now the prevention. Prevention is the mainstay of management. All this, you notice that the main thing is to prevent. Once the toxin is there, we cannot do anything about it. So the main thing is to prevent it. How do we prevent? We need to immunize our women. We need to give our pregnant women at least 2 doses of tetanus toxoid 1 month apart. And after pregnancy, we continue after a year, or in the next pregnancy, we give a booster dose till we're able to achieve the 5 doses. We'll still be informed more about this immunization. And that's the level that will be sufficient for a lifelong protection. Also, for area that is of high risk area, is also good to give, as I said, 3 spaced doses of tetanus toxoid in all women of childbearing age. Now, for World Health Organization, they look so simple, but if we're able to keep these systems, it will reduce tetanus toxoid to the barest minimum. If we're able to keep a clean bath surface, clean hands, clean perineum, cord cutting, cord tying, and cord care, there are simple things, and my sisters, we can do it. We can decide to move in and talk to the community, and they can do it, and it's achievable. In a study in Pakistan, it shows that even without vaccination, use of specialist clean delivery kit prevented about 1/4 of cases of neonatal tetanus. Also in China, they were able to achieve significant elimination just by clean environment, hygienic delivery, having skilled birth attendants, even when the immunization coverage was very low. So please, Elimination Initiative lies with specifically designed local methods. They are all local methods. We don't need highfalutin technology for us to control it. There are local ones, and they are with us. If we can do it, but the problem is that it usually affects a high-risk area in remote area, poor infrastructure, often political instability, making delivery of basic programs challenging. So we need to educate our patients. We need to train the midwives. This we can do even as M1. We don't need much. It's for us to move in and do something. But what are the challenges with us? One of the greatest challenges is, especially in Nigeria, is urban and rural dichotomy in distribution of amenities. You go to rural environments, you don't see clean water, doctors are not there, no hospital. And the neonatal cases are common among babies born in home of traditional birth attendants. If we can handle traditional birth attendants, this tetanus toxoid will be reduced to the barest minimum. Is our rural communities with limited health facilities. One reasonable approach we can do is outreach service delivery. I thank God that M1, we are good in outreach. If we say, yes, we have to focus, we have to trace those cities, those states that were having problems. We move into outreach delivery services, and the intervention will be clearing. In conclusion, my dear sisters, prevention of maternal and neonatal tetanus must remain the main goal for tetanus programs, which is now linked to the Millennium Development Goals. Research into effective therapies and prevention is still necessary. We can do it ourselves. We mustn't wait for developed countries. Effect of HIV and malaria on the effectiveness of immunization of pregnant women need to be taken into consideration in public health programs and need further study. Therefore, It is essential to begin campaigns or integrate complete maternal tetanus toxoid immunization at primary health centers during antenatal care. Immunization needs to be arranged so pregnant women can be educated regarding the importance of antenatal care and the risks of unhygienic home delivery. And immunization should be addressed with adequate information. This is one of our women in rural environments we need to care for. This is another colleague of us, another mate, another woman in a rural environment. We need to immunize them. We need to give them a voice. M1 can do it. We can stand up to fight this scourge. We can stand up and achieve this elimination. You know always that we heal with heart of a mother. Thank you. There's my references.
Thank you. Thank you, Dr. Maureen. Dr. Maureen,
yeah.
Learn it. Thank you so much for that.
Learn this, my name.
Thank you for taking the epidemiology of maternal and neonatal tetanus, including the WHO overview of the Mnte and the importance of the elimination and presentation of maternal and neonatal, of maternal tetanus and treatment. The next on our list is Dr. Lillian Ekwem. After 3 of our lectures, we will take questions. So each of us can prepare our questions, and after the 3rd lecture, we will take questions so we can, prepare for that. All right. So I'm going to introduce Dr. Lillian Ekwem. She's okay, Dr. Moore, you can log out your screen sharing so that Dr. Lillian can do.
Yeah.
Sorry about that. I'm back. So, Dr. Lillian Ekwem is a 1997 graduate of Ahmadu Bello University, Zaria, and has been a pediatrician for 10 years with work experience in both private and public health sectors. She has additional training in pediatric nutrition, autism spectrum disorder, biomedical ethics and research, and a trainer of trainers in research methodology, setting up an NGO, democratic leadership, neonatal resuscitation, PMTCT, and respiratory support skills. She has served as Treasurer ARD ABUTH Zaria, Treasurer NMA Kaduna State, NMA Chairman Interprofessional Committee on national level, Secretary Welfare Subcommittee for the LOC of PAN and UNAPSA Conference, and Secretary M1 FCT branch. Her efforts are reducing pediatric mortality due to severe malaria and diarrheal disease in specialist hospital, Damaturu, by setting up a foundation for the free treatment of these diseases, earned her an award of the Best Youth Corps Member of the Year, Yobe State, 1998 to 1999, with automatic state employment. During her tenure as the pioneer head of pediatrics, NISA Premier Hospital, Abuja, and working together with a diligent team of staff in 2014, succeeded in getting accreditation for the commencement of residency program, thus making it the first private institution to be accredited for residency in pediatrics for the West African College of Physicians. She received a letter of commendation for her performance as acting head, Pediatrics, Maitama District Hospital, 2014 to 2015. She has participated in some international multi-center scientific researches projects as research coordinator and principal investigator. Co-authored some journal articles published, including some international journals. Has presented in local medical conferences and at scientific meetings by multinationals. Attended international conferences, in one of which she was an assessor of some paper presentations. Through her professional associations and faith-based organizations, Dr. Lillian volunteers her professional services, financial and material support in both rural and urban communities. She has given health talks on various radio and television stations and collaborated with OLG, that's Our Lady of Guadalupe, and Ike Foundation in Abuja to create awareness on autism. Has worked in teams with Africa Health Development Trust Fund, Save the Children, Maternal and Child Survival Program, and Federal Ministry of Health to train different categories of health workers on acquisition of neonatal resuscitation skills in different parts of Nigeria. Dr. Lillian Ekwem is currently the co-chairman, Pediatrics and Adolescent HIV TWG FCT, treasurer, Medical and Dental Consultants Association of Nigeria, that's MDCAN FCT, M1 past representative at NERIC meetings, Abuja, and head of pediatrics, Nanya General Hospital, Abuja. She's married with children, enjoys reading, listening to music, dancing, and family time. Dr. Lillian, you are welcome. So please go ahead. She's going to, she's going to take us on the current immunization schedule in Nigeria with emphasis on tetanus toxoid vaccination. So you're welcome, ma'am. All right. You're at the bottom, so go to the top of your screen.
All right. So all right, can you see my screen, please?
Yes, we can. Yes.
So,
Yes.
Good morning.
Yes.
Good morning, everyone.
Good morning.
I want to thank the National President, our dear Dr. Mnte, and our National Clinic Coordinator, our able and indefatigable Dr. Agonle, for asking me to make this presentation. I also want to give a special greeting to my mommy in the house, Professor Okofilo. I consider it a privilege to join the same panel.
I'm seeing you too. I'm trying to see what I can.
So, I welcome each and every one in attendance at this seminar. Thank you for your time. I'll be talking on current immunization schedule.
I need madam's permission. Let me get to one. I've been
Dr. Agonle,
chatting with her.
you are unmuted. Dr. Agonle, you are interfering. Maybe you can mute your microphone. Sorry.
Oh, sorry. I know. Sorry. Sorry for distracting. Sorry. Please continue.
So, maybe okay, thank you. So I'll be talking on current immunization schedule in Nigeria with emphasis on tetanus toxoid immunization. This will be the outline of my presentation. We'll look at the MPI schedule, tetanus toxoid vaccination under certain subheadings, and then challenges with TT uptake, and then we'll look at the way forward. You know, and Dr. Omemo has made a very good presentation. A lot of what I have on my presentation is has been captured in many of what she has said, and that was quite a good presentation, exposing us to an overview on maternal and neonatal tetanus. So I'll be looking at the immunization aspect, specifically about tetanus vaccination. The expanded program on immunization, EPI, started in Nigeria in 1979 with the support of WHO and UNICEF. In 1995, Nigeria became a signatory to the World Health Assembly and adopted her resolution as well as the goals of the United Nations General Assembly special sessions to achieve by 2015 polio eradication, measles mortality reduction, and maternal and neonatal tetanus elimination, which we're talking about today. And by 2010, to ensure full immunization of all children under 1 year, with 90% national coverage and at least 80% in every district, as well as vitamin A deficiency elimination. Nigeria also adopted the Millennium Development Goals. Now they are Sustainable Development Goals, and we are yet to achieve even the Millennium Development Goal number 4, which was targeted at reducing by 2/3 child mortality. However, after initial success of the MPI program in the early 90s, where we achieved up to 81.5% average national immunization coverage, we have since then had consistent decline in our immunization coverage, and as of 2003, it had dropped to 12.9%, and recently it only came up a bit to 33%. In '96, the government changed the name EPI to MPI. This was in a bid to boost the poor performance on our immunization coverage, and but the change of name did not do the magic, because we still kept having poor performance, and the MPHCDA, where the program is domiciled or in whose custody it is, have been, blamed largely for allowing political influences that led to the neglect of routine immunization in favor of the polio vaccine campaign. Well, thankfully, we have been declared polio free, but our routine immunization has suffered a lot because of that neglect. Other factors that have been blamed for our poor national immunization coverage include poor access to primary health care services, politicization of primary health care management appointments, who it's about who you know rather than on merit, security issues, legislative enforcement, poverty, and gender inequity, amongst others. Chido Amadroi et al. Reviewed the National Health and Demographic Survey that was carried out in 2013, and it showed that our DPT3 coverage is a key indicator of our immunization in children was only 38%, and the Penta vaccine coverage was 33% among children 12 to 23 months old. And after 2013, only 23% of Nigerian children were fully vaccinated. Now, some of the reasons that were preferred, or some factors that were implicated, included mother's employment status, where a mother was unemployed, was a negative influence, poor educational levels, poor attitude towards child immunization on the part of both mother and father, large number of children in a family, and then one of the key things was healthcare providers' attitude to these clients when they come to seek for immunization services. In the north, the performances were poorer, and this were thought to be because of poverty, which was more in the northern part of the country compared to the south. Religious beliefs that, and then the rumors, it was being foiled by rumors that the vaccine contained some harmful agents and even some substances that could, sterilize our children. And so this greatly, affected the success that we could have achieved in our national immunization coverage. In 2017, only 18% of Nigerian children aged 12 to 23 months were fully vaccinated. This was a further drop from the 23% that had been recorded in 2013. So we were not making much progress. So we'll look at tetanus infection has already been defined by the previous speaker. It's caused by toxins of Clostridium tetanus. Umbilical cord. Okay. And however, it is good to note, or it is very pertinent to note, that the easiest way to provide protection for the newborn in the first 3 months of life is through maternal immunity against tetanus. And this is the source of this presentation. If we can attend to maternal immunity against tetanus, then we are sure that, we can also be happy to say that we have attacked this scourge of neonatal tetanus in Nigeria. In spite of so much global effort to reduce maternal and neonatal tetanus, especially with the introduction of the tetanus vaccine that has resulted in great success in the reduction in maternal mortality from neonatal tetanus, both in mothers and in newborns, the disease still remains, a health problem of great concern. And this is more so in developing countries like Nigeria and other countries that the previous speaker mentioned. And it's largely because of unhygienic delivery, abortion practices, and poor cord care practices that we have, in these countries. And the case fatality in neonates can be as high as 100% in the absence of appropriate medical care. And it's, rapidly progressive. There have been cases where, you have tetanus in newborns that, started a day after the baby's cord was contaminated. So within 24 hours, though some can be, have a much longer incubation period, but this tells you just how, dangerous the tetanus infection is in the newborn. So tetanus in newborn has been termed a social scourge because in spite of all efforts being made globally and in other countries where things have, where in the developed world where they have very little or no incidence of tetanus, it still remains, prominent in places where there's high level of poverty and illiteracy. In the late 80s, WHO's estimate of neonatal death was 6.7 per thousand live births. In 89, the World Health Organization urgently called for the elimination of neonatal tetanus by 1995. And I know that the previous speaker has gone into details about how all the targets that were set for the elimination of neonatal tetanus had to be shifted twice from 1995 to 2000 and again from 2000 to 2015 because there was slow implementation of the strategies put in place for elimination of tetanus in mothers and in the neonates. In 2002, neonatal tetanus was responsible for the death of about 180,000 neonates globally on an annual basis, according to the report by WHO. And this stood at 5% of all neonatal deaths, and also 5% of all maternal deaths were occurring from tetanus as a result of tetanus annually as well on a global scale. Over a 7-year period from 1999 to 2006, mothers considered to be at high risk of acquiring or being infected with tetanus were protected with at least 2 doses of tetanus toxoid, and they amounted to about 73 million globally. Currently, mothers who have had at least 2 tetanus immunizations in the world are about 75%. When you talk about the pregnant mothers, and this can range from as high as 95% in Southeast Asia, 53% in the East Mediterranean to 63% in Africa. So from in 2017, however, there was good news. There was we had achieved a 8% reduction in deaths from neonatal tetanus, and that has continued up to present. However, it's hard to note, like Dr. Momoe informed us, that up till now, Nigeria is still part of the 12 countries that are yet to eliminate tetanus, in spite of all efforts put into doing that. And our neonatal mortality rate is still high. We have the current neonatal mortality rate is 39 per thousand. While neonatal tetanus causes 7% of neonatal deaths globally, in Nigeria, it is responsible for 20% of neonatal deaths. And as WHO said, not all cases of neonatal tetanus or tetanus in general are reported. Only about 5% are reported in developing countries due to poor record keeping and their poor monitoring programs. In 2007, Nigeria was one of 27 countries, and up till now, like I said, we are still in the 12 countries at 2019, yet to eliminate tetanus. And we start to note that Nigeria contributed 30% of the 14 million unimmunized children aged between 0 to 5 years in the world in 2019. Let's see the incidence of neonatal tetanus in Nigeria. It ranges between 14.6 to 20 per thousand live births in the various parts of Nigeria, and this is worse than that of Pakistan, which is also a developing country, which have 5 per thousand. And so if you look at the distribution across the various geopolitical zones in Nigeria, you find that on a general note, the burden of neonatal tetanus is greater in the north compared to the south. You have in Kano, at 2015, 19.5 per thousand live births were the cases of neonatal tetanus that they had. Whereas in the south, if you take a place like Lagos was 48%, in Benin, 6.9%. So we know that really this guides us on where to focus our attention. When it should be a general focus, but you put in a lot of effort where the need is highest. And so it's not surprising that at the end of 2020, our national president raised an alarm over the discovery of a high number of cases of neonatal tetanus, 12 cases within 6 months that was found in Zamfara State. And that led to her alerting the State Ministry of Health for urgent intervention. So we commend that a lot. The COVID-19 pandemic, no doubt, has undeniably compounded the problem of immunization coverage in Nigeria, and has done this not only by, directly, interrupting the process or affecting the flow of our routine immunization, but also diverting attention to the issue of getting a COVID-19 vaccine. So we hope that very soon this vaccine frenzy will, ease out, so that we'll now put in more effort towards ensuring that we have a very good routine immunization program in Nigeria. The MPI schedule in Nigeria is as displayed in this table, and it contains what the schedule is like. BCG is given at birth, 1 dose, and this protects against TB. The oral polio vaccine, 4 doses. The first at birth and the remaining 6 at 6, 10, and 14 weeks. And this protects against poliomyelitis. The pentavalent vaccine is given in 3 doses at 6, 10, and 14 weeks. And they protect against diphtheria, tetanus, pertussis, hepatitis B, and Haemophilus influenza type B. And measles vaccine is given at 9 months, protects against measles. Yellow fever vaccine at 9 months also against yellow fever. Vitamin A supplementation is given in 2 doses at 9 months and 15 months to improve vision. And then we have the inactivated polio vaccine, the IPV, which is given at 14 weeks. The pneumococcal conjugate vaccine is scheduled for 6 weeks, 10, and 14 weeks of life to protect against pneumonia. And the rotavirus vaccine is supposed to be given at 6 to 10 weeks. Why I said this is why I said supposed, because it has not been fully launched in Nigeria. Even though I know that the MPHCDA is planning, to introduce rota vaccine sometime this year, 2021. So as for now, we find that you find certain states where they have rota vaccine being given routinely, but on a national scale, it's yet to be fully introduced. So on the 12th of September 2019, Nigeria succeeded in introducing the meningitis type A meningococcal vaccine, conjugate vaccine, into the country. And they're usually given in 2 doses to children who are between the ages of 9 months to 24 months. So the first dose will be given in that age group, and then the second will be a booster, subsequently in the teenage age. Current national immunization coverage, like I said, is 3%. And then you can see that our Penta-3 coverage is still less than the 90% global target. This is a table that contains the coverage for the individual antigens in percentages. You see the BCG 67%, and none of our individual antigen coverage is up to 90%. In any of our antigens, all of them are. And then if you look at the Penta-3, which is a strong indicator of immunization coverage in elimination, it's just about 50%, way below the 90% target. Okay, WHO recommends that children should have 5 doses of tetanus vaccine before 7 years, and then a booster dose 10 years after the last one. That would make the 6th dose. And this is the schedule for the tetanus vaccination as recommended by WHO. However, in Nigeria, our policy is for 3 doses to be given to the infant, 6, 10, and 14 weeks, as seen in the table that I showed previously. And then TT, that's the tetanus vaccine, to be given to pregnant women and women of childbearing age, 3 doses at 1 monthly interval. In 1990, WHO has replaced the DPT, the triple vaccine, with the acellular form that was known as BTAP due to side effects. But again, in 2012, the triple vaccine was now changed to pentavalent vaccine. That's why on the schedule, instead of saying DPT, which we know popularly, you find pentavalent vaccine there. And it contains the DPT, that's the diphtheria, pertussis, tetanus vaccines, in addition to the hepatitis B vaccine and pneumococcal influenza type B vaccine. So before we talk about the toxoid itself or the tetanus vaccine itself, we just let us differentiate, in terms of definition between vaccination and immunization. So vaccination is the process of administering a vaccine which is killed or weakened, or which is a killed or weakened organism, or its toxins have been modified in order to achieve protection against the disease. While immunization is the acquisition of protection or immunity against that disease as a result of vaccination or a previous exposure to the disease. So that's to say that an individual could be vaccinated and not be immunized. So getting the vaccine does not automatically result in immunization, as we will see in the tetanus vaccination, because the first dose of the tetanus vaccine does not confer immunity. It is the second dose that confers immunity for 3 years, and subsequently, the immunity increases with subsequent doses received. So the tetanus vaccine is an inactivated toxin of the bacteria Clostridium tetani, was first produced by Descombe in 1924 for protection against tetanus. It was commercially available in 1939 after it had been used successfully on soldiers in the World War II. And by the late 1940s, it was now combined with the diphtheria and pertussis vaccine to form the triple vaccine DPT, which has now progressed into the pentavalent vaccine. The tetanus vaccine is able to stimulate the active immune system to produce antibodies against future infections of tetanus, and that is why the more doses that one gets, the better the immune response, and then better the protection that is acquired from the vaccination. The first trial to really prove the effectiveness or the protective ability of the tetanus toxoid in pregnant women as relates with the neonate was carried out in 1961 in Papua, and there it was demonstrated that indeed a minimum of 2 doses was enough to confer protection against neonatal tetanus. In the mid 1970s, WHO included tetanus toxoid or tetanus vaccine in the EPI, and it is considered to be safe in pregnancy and in HIV AIDS patients. So a mother who is pregnant and has HIV or AIDS can still get vaccinated if she has not completed her doses. In 2006, the guideline for the tetanus vaccination in pregnancy was done by WHO, and it recommends 2 or more doses to be given to mothers in pregnancy, as this is the minimum requirement for a mother to become immunized against tetanus. And like we have said repeatedly, different workers have reported 94 to 96% reduction in infant mortality as a result of this maternal immunity against tetanus that was transferred to the baby. In 2018, WHO and UNICEF recommended that the TT be replaced with TD to ensure sustained protection against not only tetanus but diphtheria. Yeah, so in the schedule you see, instead of TT, you see TD, or TT/TD. WHO recommends 5 doses of tetanus vaccine in childhood, the 6 ones should be in adolescents, like we have said, and the additional the doses that we call the booster doses should be given at 10 yearly intervals. Maternal immunization with 2 doses of tetanus vaccine confers protection against neonatal tetanus. And like I said before, this is actually the pivot of all that we are talking about in terms of controlling tetanus. A mother gets 2 doses, not only is she protected, but her newborn will be protected at least for 3 months. And before that 3 months, the baby would have started receiving his or her own vaccine against tetanus. The first dose can protect for up to 3 years. The second dose, the first dose does not confer protection. The second dose for 3 years. The third dose can give protection for up to 5 years. The fourth dose up to 10 years. The fifth, 20 years. And then by the time you take the third one, for 30 years and even longer. So it can be given as a single vaccine, as TT or TD, or it can be given in combination. And these are the various types of tetanus vaccine: the DTaP, DT, the Tdap, and then the TD, which is being given as boosters. So the first two are for babies and young children, while the other ones are given in older children, and then in adults give the TD. So who should be vaccinated with tetanus toxoid? All babies should be vaccinated, and they get this, all newborns, that's the neonates, get this through maternal immunization with at least 2 doses of the TT injection. All children should receive TT injection at booster doses after their initial 3 doses as scheduled in the MPI. Those who miss childhood vaccinations or are not sure of their immunization history or vaccination history should also get the booster doses. Those who miss the booster dose in the last 10 years, okay, that's the 6th dose you can give. Can those who handed tetanus does not confer natural immunity, does not give life immunity. So even if somebody has suffered so much, as a result of the disease, after recovering, if he still does not take precaution, can get infected again, and then could even die from the disease. So that's why it's so essential that the vaccinations are done. Pregnant women and women of childbearing age, like we have said, if we must eliminate maternal tetanus and infect mental tetanus, it means that the mothers who are pregnant and then those who are childbearing ages, like secondary school ages and above, should be vaccinated. People who work in high-risk places where they are prone to injuries, like in factories, in the military, okay, they also should have this vaccination. What are the contraindications of tetanus toxoid vaccine? If a person has had severe allergy to previous dose of tetanus injection, vaccine should not be given. A history of coma or seizure, encephalopathy within a week of a previous dose also is a contraindication. A history of epilepsy, history of severe pain or swelling at the site of previous injection or Guillain-Barré syndrome. The side effects include mild side effects like soreness, redness, swelling at the site of the injection, fever, headache or body pain, fatigue, nausea, vomiting, diarrhea, poor appetite, and fussiness in babies and small children, inconsolable crying, and could be as severe as causing seizures from fever, swelling of the whole arm or the leg where the vaccine is given, and then anaphylaxis, brachial neuritis, and adverse reaction to the type 3 hypertension. The tetanus vaccine, like we have said, if a mother has not had any tetanus immunization in her childhood, at the first contact with her, she should receive the first dose of the tetanus vaccine as TT or TD. And then that does not confer any protection. 4 weeks later, she should get the second dose. 6 months after the second dose, she should get the third, or in subsequent pregnancies, which are delivered by then. And then the 4th and the 5th should be given, at 1 yearly intervals after the 3rd dose has been received. And then, of course, after the 4th dose, she gets the 5th one. And then the 6th one can be given, much later. And that's the one that confers a very long immunity against tetanus for upwards of 30 years. If a mother has had her childhood immunization, if she had only the 3 that was scheduled, at the first contact, she should receive a booster. Within 4 weeks, she should get her booster doses done. Okay, so and then the next one will be at least 1 year after the last dose. For those who have had 4 doses of DPT or the Penta vaccine, in our own case, she should get 1 dose of the tetanus injection or vaccine, and then later on get another one within a year. A mother got her. Aziza, please, could you? Okay. So if a mother has had thank you. If a mother has had her childhood vaccines, this is the summary of this table. If she has had her childhood vaccines, if she had only 3, she should get the remaining 3. At the intervals already stated. If she had 4 doses, that means she had the 3 scheduled and then had 1 in her adolescent period. She should have the remaining 2 as scheduled. So and so on and so forth. And if she has had all, by the time she comes to you pregnant, she has already had all the 6 doses. There's no need, for her to receive any more doses because the immunity she has, would be lasting for up to 30 years. Now look at the uptake. What are the things that have made the uptake of tetanus vaccine notifications? We are looking at this because we have already said that, in spite of the fact that vaccines are readily available and they are cheap, and other countries have been able to almost eliminate tetanus, at least they brought it down to the barest minimum. Yet, in developing countries and Nigeria inclusive, we still have this problem of maternal and neonatal tetanus. So it would be good to see what are the things that have made that, or that makes the uptake of this vaccine that is so useful, poor in Nigeria, that is making the coverage to be so poor. So in Sierra Leone and in Sierra Leone, they discovered that mothers who had as high as 4 antenatal clinic visits, that is minimum of 4 antenatal clinic visits, had a greater chance of getting at least 2 doses of tetanus toxoid, and that was as much as 82.12%. And also, it's been demonstrated, like we said before, that 94 to 96% mortality, can be taken off if a mother has immunization after getting at least 2 doses of tetanus toxoid. And so that's why it's important to know what will make this vaccine uptake to be more efficient or to improve. And what they discovered is that those who are exposed to the mass media, who get information, more information on tetanus and then the importance and usefulness of the vaccine, they were part of those that had at least 2 doses. Those who were from the high social class also, that also helped, with the uptake, because they had better access to health facilities where maternal and child services were available. In Katsina State, they found that neonates of mothers who had received even 1 dose of tetanus in pregnancy, surprisingly, were 4 times less likely to die from tetanus compared to those mothers that don't have any at all. And I would like to think that, in addition to not just the vaccine, but I'm sure such mothers, having visited the health facility and attending antenatal care, must have heard about, hygienic birth and hygienic cord care and all those others, and this would have helped, to ensure that their babies were at less risk of getting tetanus infection. In Cross River State, it was reported that there was no significant difference between the efficacy of the triple vaccine, DPT, and the penta vaccine. So that's to say that even if a child gets DPT or gets penta, the efficacy of the vaccines are about the same. So there are problems to the uptake of tetanus vaccine or toxoid in Nigeria. And several workers have reported, amongst other things, that a very young mother, tends to have issues with going to health facility, even having money, and then, she might end up not getting the vaccine. So very young age is a negative factor. Being a single mother as well, similar to that, is also a negative factor. Poorly educated mothers also do not tend to go for healthcare, and so would not have the opportunity of getting the vaccine. Those reside in rural areas with low TT coverage, and this especially because that the health facilities, they are almost non-existent, so they may not have access to antenatal care, and not talk about getting the vaccine. Poor antenatal care due to long distance to health facilities. So distance from the health facility was also a negative factor. High rate of home deliveries too by unskilled trained birth attendants, like we have heard, in unhygienic settings is also, like a very good setting for tetanus infection. And so that is why you find the infection is rampant in places where there's the tendency to have home deliveries with unskilled attendants, and then the environment is dirty or unhygienic. Also, poor cord practices. In Nigeria, we've heard about cord care with cow dung, with herbs, with hot fermentation. Hot water is so common, even in the South. You see, people generally mothers like this idea of using hot water to treat the cord, and the process, some get burnt, and then, they create a conducive environment for the tetanus spores to grow and multiply and begin to vegetate. Using unwashed hands, bare hands. to treat the cord. In the north, sometimes there's this practice of putting the hand on lanterns, heat it up and put it directly on the cord. And also using piece of clay heated also over fire or over, heated up and then place directly on the cord. And like we know, the spores of tetanus are, they are everywhere, especially in soil. And so where these spots are kept on the ground, on where you have sand, you have dust, and then place directly on the cord, of course, that will encourage the tetanus infection from setting in. Places like the IDP camps, have become a problem. Here you find a lot of challenges with, getting them vaccinated because, the environment there they are stressed up, they don't have access to good health care, and then they may not be able to even get the vaccine. Also in security compromised areas and hard to reach areas, maybe because of the topography of the community, or they have a lot of security problems like we're experiencing in Nigeria now, has worsened since 2014 when it was first reported as a hindrance to TT uptake. It's even worse now. So, these are some of the challenges we are facing. It's not Nigeria alone that is experiencing this. India, Pakistan, Ethiopia, they have also reported similar factors that impede the uptake of tetanus vaccination. And in addition to what we earlier stated as our problems in Nigeria, they also mentioned family size. Family size is a problem. Large families, where they have so many children, the mother may not really be, favorably disposed to getting them vaccinated, or the mother keeps having so many children, she might not at this stage even want to access care, and she rather just have her babies in the house and all of that. And that sometimes amounts to large family size also in some instances will equate to poverty, and that's another factor that will encourage the lack of uptake of the vaccine. Fear of side effects and myths about the vaccine is a very big factor. So if we think it's just Nigeria, it's not true. In Pakistan, they have that as a very big problem. People are afraid. Even in Ethiopia, people are scared of taking the vaccine. They have all kinds of theories about it, and so they do not go for it. And at the end of the day, these problems persisted in these countries. And Ethiopia is has one of the highest maternal mortality and the neonatal mortality from tetanus in the world. Then Nigeria is not much better because you see we have 66 to 74% of our mothers, almost 75% of our mothers being unimmunized in certain parts of Nigeria. They have been reported even in the south, not just in the north, though it's worse in the north, but also in the south, the percentage is really quite high. Elimination of maternal and neonatal tetanus, is the way forward for us. We want to look at, okay, what do we do to make it better? Dr. Omenwo has really, gone to town about, the method by which, we could achieve this elimination. I would just like to add a few to some of the things that she has said. Okay. So, like we said, the focus will be three-pronged, and that is, ensuring that there's high TT immunization coverage in pregnant women, hygienic delivery, and cord care, and then identifying and implementing corrective strategies in areas that we consider to be high risk. Like we have said, majority of these infection and death occur in the rural settings, and so our focus, really has to be in those areas that are high risk. So we can do this by addressing urban-rural dichotomy in terms of the, we have this inequality in our health facility distribution. Most of the health facilities are in the urban centers, whereas the majority of our population resides in the rural areas. And it's in these rural areas that they do not have the necessary health facilities. Okay, even water, they don't have it. So how do you maintain a sanitary condition in that case? The mother delivers with lots of blood secretions and everything. If they don't have enough water, just managing to get water to drink and for just their basic needs, they may not be able to maintain proper hygiene. And so this is a big problem. So this has to be addressed. Also, mothers who still, in Sierra Leone too, they discovered that, even though they have a very high prevalence or tetanus immunization in pregnant women, still a lot of the mothers prefer to deliver at home. So I think their focus is now, okay, you prefer to deliver at home, let us make it hygienic, and when you are done, make sure that you continue with your immunization schedule. Mass outreaches for tetanus vaccine is another way I want to intervene in the rural settings like we have said. So you just go out, and begin to organize mass outreaches to vaccinate women of childbearing age. That should be the target when we do this. And then also for mothers who may not have had, tetanus vaccine will be included. We should try and close the knowledge gap or ignorance about tetanus in order to produce behavioral change, that will help to, increase the uptake of tetanus vaccine, and then also help improve our attitude towards hygiene and good cut care. We should encourage our people to discard harmful traditional practices. Can be difficult, like scarifications. We know that in certain parts of Nigeria, for example, the scarifications are considered to be, a way of identification. So how do you convince them? So that's the reason why we must go to the basics. We must go to the community level, to the leaders, the tribal leaders, religious leaders, to disabuse the minds of people concerning the myths associated with vaccines, and also these traditional practices that they can do without them. In some parts of Nigeria, euphilectomy is common, and it's one of the ways by which tetanus can get into the newborn. And so this can be discouraged, and people can be taught proper cut care. Simple hygienic things that they can do, hand washing, and then using the proper means to care for the cord without putting all these other things where they could have acquired the spores of the Clostridium tetanus. Proper monitoring of health programs also is very, very essential. You can put everything in place. If you do not monitor, you do not evaluate, you do not come out with results of what you have done, you wouldn't know whether you're making progress or not, and you wouldn't know how to move forward from there. Now, this is how WHO has put maternal and neonatal tetanus elimination strategies. It has classified them into various has been organized into various sections to be able to ensure that we have success in eliminating tetanus in the world. So the requirement for this program is there should be a national policy and strategies in place to increase coverage with proper implementation of those policies. So Nigeria, for example, now we must have the ability or the willpower to implement our national policy on tetanus immunization. And then we should also have strategies for high-risk approach where indicated, including vaccinating women of childbearing age. So we know that these women are, at high risk, and they will know the communities where they are at high risk. So we'll go there and address, and make sure that these strategies are well implemented in this area, so that we get as many as possible vaccinated even before they get married and before they start having children. They would have completed their immunization, their vaccines, the doses, and then they will have very long protection for themselves and for their newborns. Yeah, and then when the babies are born, they now commence their own vaccination from 6 weeks. All pregnant women should attend antenatal care or have full birth attendance for home deliveries. We said this. Okay, antenatal care providers should be trained on tetanus immunization. So they should know the schedule. They should be able to know how it is given, and then know the schedule for it. Vaccine equipment and supplies should be readily available for tetanus vaccination. So it's not for mothers to come and then they want to get these vaccines, or people of childbearing, the women of childbearing ages will come, they want to get tetanus vaccination, and then the health worker says it's out of stock. It's very discouraging because some of them just manage to scrape the money for transport from where they are staying, most times very far from these health facilities, to get there, only to find that, the vaccine is not available. It means that, we have a lot of missed opportunities. They might never come back again. Effective tetanus vaccination monitoring system should be in place. There should be vaccination register. We should have vaccination cards which are kept by the mothers, and then we should have maternal health records properly kept. Okay, thank God now we have this electronic health system where medical records, where we can, have things computerized instead of files that can easily get soaked, get burned, get missing, and all of that. Okay, all pregnant women tend to attend. Well, all pregnant women should attend antenatal care with their vaccination card. So this should be something that the health workers must insist upon when they are being educated, when they are giving the talks to the mothers. They should tell them that every time you come with your vaccination card, because this helps to verify, what and what the mother has had, and then what should be the next dose she should take and at what interval. All right. Health education activities for greater community awareness is key to the elimination of maternal and neonatal tetanus. So if health education is given on the importance of tetanus vaccine, and they know how it should be given and all other things that they may need to know, they ask their questions, and then of course you help them to do away with their fears and their doubts. it will help us to, have better uptake of our tetanus immunization. Inclusion of maternal and neonatal tetanus in our national surveillance system is also another thing or another requirement if we must eliminate this scourge. Then we must apply the standard. And then when it comes to maternal immunization, healthcare workers should follow standard universal precautions for preventing infection in maternal and neonatal care. So when attending to mothers and newborns, healthcare workers should be seen to be following those standards, wash their hands, use gloves where it's needed, make sure that, they do not even expose these babies or the mothers to getting infected. They should give TT to mothers with tetanus-prone wombs, like I've earlier been said, or who have had unsafe abortions. Then before administering the vaccine, it should be well mixed, so they should know how to mix it, not shake, just gently, move the vaccine up and down. Check for damages, because once it is damaged, it must not be used. And they must properly store the vaccine. It should never be frozen. And if it was mistakenly frozen and thawed, it must never be used. If a woman was unvaccinated or her status unknown, she should be given 2 doses of the tetanus vaccine 1 month apart before delivery. And the 3rd dose should be given 6 months after that, the 4th and 5th at yearly intervals, like we have said. If she's fully vaccinated, she has had her child's vaccination, and she has the card to prove it, don't assume she must come with the card. She should only get the booster dose. And the last dose, the last booster dose you give should be at least 2 weeks to delivery. So the health worker must know these things. Otherwise, they may just give these vaccines, improperly, and at the end of the day, will not be able to achieve our aim. So then there should be good record keeping. All the vaccines, dates of vaccination should be kept in the card, and the card should be left to the mother, while the immunization register in the health facility should be kept in the facility with these dates recorded in there and their names. In case of neonatal tetanus, if there's a case and the health worker has attended to the baby appropriately, the mother should be vaccinated immediately, because that means for the neonate to have had an infection, the mother most likely does not have immunity against tetanus, and so she should get vaccinated. She should have at least 2 doses, like we have said, according to the schedule, and then there must be a search carried out in that community for other cases, like the case of Zamfara. I'm sure the State Ministry of Health must have gone searching for other cases, because where you see one, you need to look for others, and then put in measures to mitigate future occurrences. Then report all cases of neonatal tetanus to relevant district authority and investigate all cases from low-risk communities. We should also record and report all cases of tetanus in other age groups. This is important because it gives us the opportunity to be able to highlight maternal tetanus, because where you have maternal tetanus, it's also going to weigh on neonatal tetanus. So if you get the case of maternal tetanus, you should alert. And the generalized tetanus and the cephalic tetanus are reportable cases, so they must be reported to the relevant local authorities. Monitoring and evaluation must be done. It's a way of auditing all that we have put in place to ensure that we get the desired results. So input indicators include national policy and strategies and plans for maternal neonatal tetanus in health facilities. Antenatal care providers should be aware of the vaccination schedule and how to check for damaged vials, like we have said. TT or TB should be available in health facilities at all times where maternal care services are offered. Community-based health education activities and outreaches to create or increase awareness on tetanus immunization and antenatal care should be done. Okay, and then like we have said, we must carry along the traditional leaders. Then we also look at the process and output indicators. This tells us whether we are getting what we have set out to achieve. We look at the proportion of antenatal care services that offer tetanus immunization, the proportion of pregnant women with at least 2 doses of tetanus vaccine, or the proportion of neonates that are protected at birth. So this means that if a mother has had at least 2 doses of tetanus vaccine, it is indirectly a way of looking at the proportion of neonates that are protected from tetanus at birth, because maternal immunity will cover the newborn up to 3 months, the first 3 months of life. There should be monthly reports on neonatal tetanus cases completed and delivered on time. One of the problems that occurred in 2013 was that there were no records, they were not being delivered on time, and things were just not in order. So other indicators that will show success of all the strategies put in place include incidence of neonatal tetanus, and this is defined as at least one case per 1,000 live births per district. So if we say we have eliminated neonatal tetanus, it should be that we have less than a case per 1,000 live births per district, and the same applies to maternal tetanus as well. So the target is the same. So effective surveillance is crucial to monitoring and can be done even in soft spot settings, because to be able to keep records in a register, to be able to give health talks, to be able to create awareness does not really require much money. And to be able to monitor all these strategies that have been put in place also do not require much resources. So even in resource spot settings that we find in Nigeria and rural settings, it can be done. So long as these facilities are kept there, the health workers are trained, they know what to do, we create awareness and everything, we'll be able to effectively, monitor the programs, our health programs, and be able to achieve great success. The Federal Ministry of Health through the MPHCDA has a comprehensive EPI multi-plan for 2016 to 2020. And there, the target stated there was, to reduce maternal mortality rate by 3/4 and under 5 mortality rate by 2/3 between 1990 to 2015. However, in 2013, the under 5 mortality rate was as high as 117 per 1,000. Infant mortality was 69 per 1,000. Maternal mortality rate was 576 per 100,000. And 51% of mothers were having at least 4 antenatal care, which was good, but only 36% of them delivered, under the attention or under a skilled health worker. That's to say that the rest of them still had their deliveries at home with unskilled birth attendants. So now the MPHCDA has put in new strategies going forward, be able to effectively reduce maternal and infant mortality, among others, including community mobilization and ownership. And this is very key. If the people in the community do not have a sense of ownership, or they've not been made, to take ownership of these programs that we put in place, it will not succeed. If they see it as government programs, they will not cooperate, they will not participate, they will not utilize the services, and at the end of the day, we'll be right back to where we started. So the community must be well mobilized, and they must take ownership of these programs. Also, tetanus cannot be eliminated biologically. We all know that, because the spores are everywhere. You just cannot eliminate them. Okay, but we sure can eliminate maternal and neonatal tetanus, and this can be done through the strategies we've mentioned. Okay, especially talking about the 3-pronged strategies of high tetanus immunization among pregnant women and women of childbearing age, talking about hygienic birth delivery and birth and cord care, and also talking about implementing the strategies effectively, monitoring those processes, those facilities, health facilities and programs we have put in place to ensure that we are on the right track. And where we find that there's a problem, we can always, re-strategize, and then we'll be able to achieve our aim. So the MNT initiatives are aimed at reducing maternal and neonatal tetanus to a level where it ceases to become the major public health problem that it is currently. So in conclusion, I want to say that maternal and neonatal tetanus is a consequence of unhygienic delivery and umbilical cord care in most cases, and these are indicators of the inequitable access that prevails in our country, to free tetanus immunization and other maternal and newborn health services. Prior to the advent of tetanus vaccine, like we have heard happening in other in other countries, the scourge of neonatal tetanus was combated through simple, strict hygienic child birth and cord care practices, and that was what Europe and North America needed, to make tetanus almost non-existent in their climes. Therefore, deaths from maternal and neonatal tetanus in Nigeria can certainly be preventable. They are certainly preventable if we work hard to implement and monitor measures that will ensure that mothers have access to antenatal care, tetanus vaccination, deliveries in health facilities, hygienic home deliveries where they choose to have one, with skilled practitioner birth attendants and good practice. So finally, I want to commend our dear National President, M1, Dr. Mnte, for creating this fresh awareness on the scourge of maternal and neonatal tetanus after the discovery of the high occurrence last year in Zamfara State, and for notifying the State Ministry of Health for urgent intervention. I really want to thank you for your time, and thank you for giving me the privilege and the pleasure of making this presentation. Thank you very much. So here are my references. Hello, Dr. Agbonle. Hello, Dr. Agbonle. Hope I'm not repeating myself. She's not responding.
All right, sorry, I'm back. My internet went on. I'm
Okay.
sorry.
I
Dr.
was
Lillian, thank you
wondering.
very
Okay, no
much.
problem.
I'm here. I'm very.
Okay.
Good afternoon, all. Sorry about that. It's internet issues. Dr. Lillian, thank you very much for your lecture.
You're
We're
welcome.
very
Thank
grateful
you.
for that expose on the current immunization schedule in Nigeria with emphasis on the tetanus toxoid vaccination in Nigeria. We know we are trying to make sure that we do every preventive measure to make sure that our women and children are protected.
Yes, no.
Hello? Oh, so sorry. I hope I don't apologize again.
Your
Our
network
next
is
speaker, is going to be our dear, darling Professor Angela Annene Okolo. And she's our teacher. She has been a teacher to a lot of us, and we owe her a lot of thanks and honor today. So I'm here to welcome Professor Angela Annene Okolo. She is going to take us on hygienic delivery and cord care in hospital and non-hospital settings, infection prevention and control. Now, I'm going to give a short citation before she comes up to speak. Citation for Professor Angela A. Okolo. Angela Annene Okolo is a physician, pediatrician, and specialist in neonatal health. Her educational background has provided her the opportunity to serve at both international and national level activities. Her early formative years in medical school at the Lovenium University of Kinshasa, DRC, has made her a bilingual doctor. She is a fellow of the Royal College of Physicians and Surgeons of Glasgow and a fellow of the Royal College of Pediatrics and Child Health, UK. She is a fellow of the National Postgraduate Medical College of Nigeria and a fellow of the West African College of Physicians. As a professor of pediatrics with accrued experience of more than 25 years at the medical schools in University of Benin and University of Jos in Nigeria. She's a prolific writer, author of several scholarly publications, and contributed to book chapters. She has been active in postgraduate medical education activities at national.
Hello, Joy.
We need to mute ourselves, please. Please mute yourselves. Thank you. She has been active in the postgraduate medical education activities at national and regional levels. She has trained and mentored many pediatricians and senior pediatricians in Nigeria. She is a 2014 Distinguished Pediatrician Awardee of the Pediatric Association of Nigeria. She's the 1986 to 1987 Irene Ighodaro, gold medal awardee of the Medical Women's Association of Nigeria. She is the, what happened?
I just wanted to put somebody inside to just.
No.
Okay, this thing I was pressing all time. So it now came out.
Hello? Can we still hear me?
I can't hear a thing anymore. I can't hear anymore.
We can hear you. We can hear you.
You can hear me? Okay, all right. So sorry. Prof, can you hear me, ma?
Yes.
Okay, good. She's currently the advisor to the Nigerian Society for Neonatal Medicine. Her long-standing experience in the practice of pediatrics and child health, perinatal and neonatal health has oriented her activities towards identification of disorders that impair attainment of optimal potential of the child. Hence, her interest in the newborn screening programs and community pediatrics. She has accrued experience in health management and management of health projects, has the capacity to work in a multicultural environment. She has been involved in regional and national pediatric society activities for more than 25 years. Please let us welcome our darling Professor Angela Annene. You're welcome. Please, the floor is yours, ma'am.
So thank you very much. I'd like to share my screen.
Please stop.
Yes,
We
ma'am.
are not seeing your face. We are seeing only your brow.
Okay. You will soon stop seeing my face because I'm sharing my screen now. Distinguished audience, I'm going to speak for the next couple of minutes on the topic highlighted, but I will be applying the concept of hygienic delivery and the notion of prevention, infection prevention and control to this given topic of elimination of maternal and neonatal tetanus. So again, thank you to the organizers of this forum for inviting me to participate. What you have not heard is that I have been a past president of the Medical Women's Association of Nigeria. So these are my presentation plans. I'm going to shortly talk about the objectives, the burden of the disease, the solution, because if I am to talk about the topic highlighted, as I had told you, I am just going to apply the concept of this topic to the given situation of the burden of disease we are encountering. And the solutions would be in the 6 claims. I will adduce evidence for utilization of the model I'm going to propose with available literature. We'll be drawing conclusions and way forward and make concrete recommendations to MWAN. So as part of my objectives, we need to, I hope that we would be able to understand the emphasis and the rationale that underlies the maintenance of clean delivery and postnatal care environment and the need for implementing infection control measures through the process of caring for mother and the newborn. This will enable rational approach to implementation process, so hygienic delivery and clean postnatal care. We know that there are over 520 newborn deaths from neonatal sepsis, and 60,000 of these are from neonatal tetanus. 30 to 40% of infections resulting in neonatal sepsis and deaths are transmitted at the time of delivery. Infections are also transmitted in the postnatal period through contact with unhealthy environment. In Nigeria, neonatal sepsis is one of the 3rd major causes of neonatal mortality. And sadly to note, tetanus is still a major killer. In the lower middle income country settings, about 60% of births occur without a skilled attendant at delivery, and mostly in their homes. You have heard the previous speakers have alluded to this. So globally, 60 million births happen outside facilities, and even for facility births, hygienic practices may be suboptimal. Worldwide, tetanus contributes to a large proportion of maternal and neonatal deaths. Infections commonly occurs after unhygienic delivery and cord care practices. Eradication is impossible, therefore, like you heard from the previous speakers, the goal of the global preventive strategies is to reach elimination of the disease. Implementation of the maternal and neonatal tetanus elimination initiative hinges on two main strategies: the strategy of increasing immunization coverage and that of clean delivery and cord care practices, to a large extent that of surveillance as well. Now, what are the sources of infection in hospital and non-hospital settings? These infections, like we mentioned, are acquired during birth and postnatal period. The umbilical cord and skin of the infant are major sites for contamination. And it's important to note that traditional beliefs and cultural practices strongly influence care of the cord and skin. As I had learned over time, the cord is the baby in our cultural setting. These symbolic meanings, which extend beyond the newborn and the newborn period, in turn influence the various practices of umbilical cord care. Ensuring optimal cord hygiene at birth and during the first week of life, including the use of chlorhexidine, especially in settings having poor hygiene, is crucial strategy to prevent life-threatening sepsis and cord infections, and to avert preventable neonatal deaths. However, care and education must be exercised before the introduction of any new intervention into a program for the success of uptake of that intervention. Most of the neonatal deaths occur in countries from sub-Saharan Africa and South Asia. You have heard all this, generally in areas where poverty is rampant. Globally, tetanus still exists in 14 countries. Mothers lack access to quality antenatal care in such countries. They lack access to adequate information about clean delivery practices, since most of the deliveries happen in the home. They lack access about knowledge of helpful practices for cord care, and so utilize applications of harmful substances to umbilical stump. This even happens in large cities, in pockets of poor urban slums where access to healthcare facilities are supposedly better than in rural areas. Here, we're highlighting the countries where maternal and neonatal tetanus still exists. You can see our own country still in that highlight. Semmelweis had actually identified in the 18th century the etiology and epidemic nature of puerperal sepsis, but this was not heeded to, because at that time he introduced for prevention hand washing, which lowered the incidence of maternal. Practice was only institutionalized much later in 1998, when WHO published a review of evidence for care of umbilical cord and summarized clean delivery and cord care practices as the 6 cleans. It is now well recognized that WASH is good prevention strategy. Prevention of these infections involves practicing 6 cleans along with increased coverage tetanus toxoid immunization. In regions of the world where vaccination and immunization are now viewed with suspicion, promotion of these 6 clean practices is a pragmatic step. Here we have the 6 clean practices, and the pillar of which I consider the pillar hand washing. Even when we have to wear gloves, hand washing is crucial. Delivery surface cleanliness and hygiene, cutting of the cord, handling of the cord, refined cord cutting, cord tying, cord nursing, and bathing and cleansing of the babies. In these 6 pillars, I have added breastfeeding and timely initiation of breastfeeding because babies can still be contaminated through their feeds. The concept of clean delivery, what is it? We may use clean delivery kits in health facilities or outside hospital because this connotes the concept we are trying to talk about. The use of the kits is not always associated with practice of clean delivery at home anyway. In the context of clean delivery practices, we find that washing of hands and wearing of gloves are crucial. Specific clean delivery practices will include hygienic practices, particularly with instruments used during delivery. These include 4 specific clean delivery practices, such as use of boiled blade and thread, hand washing, use of gloves, and plastic shield. These, when combined with the use of delivery kits, are associated with neonatal mortality reduction in deliveries conducted in the home setting. Supplies are required for carrying out the 6 cleans. These supplies include soap to wash hands and perineum, a clean blade to cut the umbilical cord, and clean thread to tie the cord. Scarcity of these may be a limitation to implementation. You can imagine that these are simple, but they can be scarce where poverty is rampant. Limitations to the practice implementation include availability of supplies, and in fact, more importantly, acceptability of the process. Hence, the need for sensitization and health education to tackle the complex behavioral change needed to make sure that delivery attendants or traditional birth attendants in the community practice these 6 claims, and that there is cultural acceptability to the women and their families. In the earlier presentations, it was highlighted that the mothers-in-law were obstacles to immunization. So we need to tackle such things. Therefore, universal access to clean and hygienic child delivery requires addressing these bottlenecks on both supply and demand side of the health system. Some interventions exert effects through multiple channels. For instance, with clean birth kits, this may influence both content of care and uptake. WHO has been endorsing supply of clean birth kits that are disposable in resource-poor settings for many decades. This is seen as cost-effective way of providing minimum necessary birthing provisions to promote hygienic deliveries and cord care. Clean birth kits are also highly encouraged in hospital facilities where sometimes hygienic practices are not always possible because of improper sterilization techniques and limited supply of water. I think it's applicable to our setting in a lot of instances. Clean delivery, clean birth kits provide minimum but necessary supplies for carrying out a clean delivery in one affordable package which can be cheaply available to mothers and birth attendants. The contents of these sterilized disposable packages facilitate 6 clean practices, which are the plastic delivery sheet for clean, safe surface, a soap to ensure clean hands and perineum, a blade for clean cutting of umbilical cord, cord ties and ligand for clean tying of cord, and finally, gauze and spirit for clean post-delivery cord care. Most of these kits also contain a pair of gloves for carrying out clean delivery. Availability of skilled birth attendants who have access to clean services in healthcare facilities are crucial in reducing neonatal deaths. While this is accepted as benchmark, skilled birth attendants availability alone is not enough to bring down neonatal mortality in a short period of time in less developed countries. Here we have the illustration of what a birth kit contains. We have the gloves, we have the cord ties, we have soap, we have the plastic cover for the surface, birthing surface. We have blades, we have spirit sponges for cleansing of the cord post cutting. Now, let us look at some solutions that we can proffer. Where there is chronic lack of skilled attendants at birth, and where the traditional birth attendants practice deliveries, and where there is poor access to clean delivery services and poor supply, clean birth kits seems a cost-effective strategy. Meta-analysis and literature reviews on the use of disposable kits have indeed provided clues on an increase in clean practices by attendants, even when it's as simple as cleaning of hands. You heard that during the last presentation, during and after child delivery. Lower incidence rates of a range of infectious outcomes have been observed. In regions of the world with poor coverage of tetanus toxoid immunization, clean birth kits appear to be an effective strategy to achieve sustainable development goals of reducing maternal and neonatal mortality. However, in order to further accelerate progress towards SDGs in developing regions of the world, a major focus must be placed on increasing coverage of immunization and quality of antenatal care. In the process of these implementations, evaluations are needed. We have some evidence here. In many countries, maternal and neonatal tetanus were eliminated through clean delivery practices even before vaccines were introduced. Clean care practices through delivery assistance have been shown to be an effective intervention in reducing neonatal mortality by 50 to 70%. In China, the success of eliminating maternal and neonatal tetanus in 2012 was credited to clean delivery practices and increased facility-based deliveries without specific vaccination scheme. A study carried out among the Maasai tribe in East Africa has shown that interventions to improve delivery practices sharply reduce mortality from maternal and neonatal tetanus, even without vaccination programs. Even though clean practices have already shown to be effective in reducing mortality in regions where most of the deliveries are carried out in homes, maintaining these practices, even with skilled attendants, remains challenging because some of our skilled attendants may not even understand how to do hand washing in a proper way. Clean birth kits to ensure clean practices have been shown to be a promising strategy in reducing maternal and neonatal morbidity and mortality. A systematic review by Blencow et al. Suggests that these kits to improve clean practices are highly cost-effective. Previous study from Pakistan reports that provision of skilled attendants and clean birth kits is independently associated with reduction in neonatal tetanus. I think the previous speaker alluded to this. The population attributable risk for not using birth kits was 24%. This means that approximately 1/4 of neonatal cases can be prevented with the use of these kits. In regions of the world with poor coverage of tetanus toxoid immunization, like us, clean birth kits appear to be an effective strategy to achieve sustainable development goals of reducing maternal and neonatal mortality. And we are looking at further evidence from the review by Blencow and her co-workers, where they showed that facility birth compared to home birth was found to reduce the risk of death from neonatal tetanus by as much as 70% after controlling for major confounders such as immunization coverage. Blencow's meta-analysis also found that intervention studies that included clean birth kits were associated with improved outcomes in neonatal tetanus and encephalitis. The evidence for the effect of these kits on neonatal outcomes was, however, not high, and the results may not be generalizable. All studies in the analysis included clean birth kits as part of evaluation package alongside other interventions using different delivery mechanisms and with different background characteristics. For example, the intercurrent practices and background tetanus rates in the situation. Even though clean bed kits have shown to have potential to improve quality of care at birth, some questions still remain. One important issue to understand is whether mothers using the kits act as a disincentive for giving birth in the hospitals. In the report from rural Uganda that was evaluated, it was a survey of 6 delivery practices. Post-delivery razor blades and string use was as high as 90%. Ironically, delivering on a clean surface was low at 30%, while 90% of the interviewees used borehole water for cleansing of the baby, but no mothers washed hands after latrine-related activities, compared with 83% of them who washed hands for food-related activities. Again, this is traditional, I would say. None of them delivered in health centers or with skilled attendants at birth. In this survey, respiratory infections occurred in 8 neonates compared to 2 ophthalmic infections, but there was no diarrhea. The study concluded that the use of clean delivery surfaces needs to be improved, as well as hand washing after latrine-related activities. Diarrhea was far less common than expected, since rural mother-infant pairs spend the majority of their post-delivery time around homes. Hygiene impacts neonatal infections to a large degree, possibly even more so than delivery practices. In the same study of these 6 delivery practices, in their evaluation, the use of clean birth kits when neonates were given colostrum, whether the mother or birth attendant used soap to wash hands, was evaluated. And they were decided as being satisfactory or unsatisfactory. The mother-infant pairs were assigned to scores that range from 6 to 12 points for satisfactory performance or unsatisfactory performance. It is worthy of note to indicate that none of the mother-infant pairs scored 100 for satisfactory on all the 6 delivery points. And 60% scored unsatisfactory on all the practices. And amongst these 60%, 33 had both respiratory and ophthalmic infections, whereas 33 had no infections and none had diarrhea. Of the other 40 who scored more than 60% and were satisfactory, all had respiratory infections, but none had ophthalmic infection or diarrhea. In that same community survey, traditionally in their culture, when a woman delivers alone without assistance, she is praised. She also remains in that hut without bathing or eating until the baby's cord drops off. One of the women engaged in this practice. The practice can be detrimental to neonatal health, particularly when colostrum letdown is delayed. She would have nobody to talk to. Because postnatal period is a crucial time for identifying infections and seeking care, isolation of the mother and neonate from the community is an especially risky tradition. These women had access to boreholes and clean water, but more readily washed hands for food than after lavatory use or before feeding their baby. In conclusion, the researchers said that there was frequent use of post-delivery razor blade and threads, but improvement was needed for clean delivery surfaces. There was an acceptable amount of washing of hands in food-related activities, but not after defecation. No woman delivered with a skilled birth attendant. Respiratory infections were common, but there were no cases of diarrhea. It is recommended that behavior change communication in this their community survey, the communication materials should refocus the benefits of initiation of breastfeeding immediately after birth and the benefits of utilization of sanitary bed surfaces they should be taught alongside the skills of hand washing after defecation. Another qualitative survey from Ghana showed where they evaluated the understanding of clean delivery. It showed a widespread understanding of the need for clean delivery in this rural community of northern Ghana. However, despite the fact that they seem to have understood, it was not borne out in practice because many recommended clean delivery practices were ignored. Community engaged in harmful traditional practices for cord care and delivery. There was increasing use of facility delivery. That's on the good side of things. There was a disconnect between healthcare providers and the community, and the critical role of grandmothers played in ensuring clean delivery practices was also identified. So when we look further at the role of hygienic behaviors during childbirth and during early postnatal period in infection transmission, it is well recognized that the contribution of sepsis and tetanus to morbidities and mortality is also quite high in our setting. How do we move from here? We need to learn from Kenya, who achieved elimination of maternal and neonatal tetanus in 2018. They were declared by WHO. I am sure this was achieved through increasing coverage for routine immunization and supplementary immunizations. However, attainment of maternal neonatal tetanus elimination for Kenya will certainly positively impact on neonatal mortality for tetanus. It may not affect neonatal infections if focus is not given to clean birthing, clean and hygienic practices at delivery. Again, we cite another evidence for this in use of birthing kits for clean birthing. The second elimination strategy hinges on birth hygiene or practicing clean deliveries. The importance of clean delivery practices has been emphasized over time. The issues are how much of hygienic practices and infection control can we confidently guarantee in our health systems and our communities presently? Because we have issues with running water, don't we? If uncertain, then it's best to revert to the use of clean birth kits. However, on many occasions, when these supplies are available, there is need for complex behavioral change to make sure that delivery attendants or traditional birth attendants in the community practice these 6 cleans, and there is cultural acceptability to women and their families. This was evidently borne out in the work of Jessica and co-workers in Jigawa. They showed that there was low utilization of the clean birth kits that was being distributed. It suggests to us that the influence of cultural acceptability on the non-use of the clean birthing kit and the show highlights the need for intensive mobilization and education alongside implementation of such projects. Again, Zara and her co-workers had shown that the use of CBKs were associated with reduction in perinatal, neonatal, and young child mortality. But it also highlighted the lack of awareness of the importance of CBKs and clean delivery practices. They noted also that there were financial barriers as the potential bottlenecks. These highlights of this, in my view, will be the kind of problems we would encounter as well in our country situation. Despite the limited evidence for the use of CBKs, further work should be encouraged as we continue to gather more evidence for the use of CBKs, which appear promising strategy to reduce maternal and neonatal mortality and morbidity from tetanus. Postnatal care attention should refocus care of the umbilicus and skin The use of the antiseptic for cord care should be addressed, as chlorhexidine for cord care has been institutionalized in Nigeria since 2014. There is still room for continued education of our populace on its use, because many of our mothers don't even know the value. They mix the practice of the use of chlorhexidine with other things they do apply to the cord. As part of the clean hygienic practices and essential care for the newborn, bathing of the baby should be delayed till after the first 24 hours of life, and the vernix should be left in place during this time as a protective means against infection. The specific use of chlorhexidine for cord care was uniquely tested in 3 trials in Nepal, Bangladesh, and Pakistan in the form of 7.1 chlorhexidine before, in 2013, the World Health Organization added chlorhexidine to its model list for essential medicines for children. And currently, it is now, the WHO has issued a guideline on umbilical cord care, which included a formal recommendation on the use of chlorhexidine. But intensive education on its use should be pursued, as there is still room for continued education on the use of these products in Nigeria. Many of our mothers don't know about this. There is the need to conduct implementation research on clean delivery practices that should be backed with good documentation and data collection on the activities. Results of assessments of cultural beliefs and traditional practices should be factored into program implementation when we decide to implement a trial. Implementation should be backed with continuous community mobilization and education. We have the capacity, whilst attempts to increase facility delivery is continued. Efforts towards provision of supportive environment for clean delivery and post-delivery community home-based services should be fostered. Health workers and TBA's education for clean delivery services should be strengthened, as they would provide CBKs to both the PHCs and the communities, and the utilization will be monitored. Possible roles for one nationally. It is very contextual, because one has adopted communities in the states. Can we integrate education for clean deliveries as part of the Worthy campaign, health education on several aspects of the cleans, provision and use of CBKs, and we should, before we introduce the CBKs, we should increase awareness for clean deliveries and use of health facilities. Community education and sensitization for acceptance and implementation of the 6 cleans at hospitals and home and at PHC and community towards elimination of maternal neonatal tetanus in Nigeria should be fostered. So one, kudos, sustain and foster this campaign. Boost tetanus immunization of pregnant women, and possibly add in one's activities the conduct of SIAs, because the previous speakers have alluded to it. Let us integrate this. Can one distribute and utilize the clean birth kits after intensive education and training of health workers and traditional birth attendants on its use as a means of ensuring clean delivery at birth? One should facilitate improved access to CBKs. One should supervise, document, and monitor implementation of these activities as they continue to increase community awareness on the importance of assuring hygienic delivery and cord care in hospital and non-hospital settings. And they should monitor the activities and document. That's the only way forward. We should increase immunization uptake and coverage for maternal tetanus toxoid towards elimination of this disease. One can take Nigeria to Mnte. And let us be acknowledged in no distant future for having eliminated MTNE in Nigeria. I thank you for listening. Here are my references. Thank you.
Thank you, thank you, thank you. Thank you, Prof. We have been enlightened and enlightened from Okay, I'm back again. Our darling Prof, we wish to thank you for that lecture on IPC. And right now, we're going to ask questions. We're giving our participants 20 minutes, or however it's, however it should be, to ask questions. So from Dr. Maureen to Dr. Lillian to Prof, we are all allowed to ask them questions now. So if you have a question, please could you raise your hand so that I can unmute you? Anyone with any question? Anyone with a question? I hope you can all hear me. Hello?
Yes, we can.
Yes, we can hear you.
Okay, all right, okay. So, any questions?
Yes.
Okay, please go ahead.
My question is about.
And who is your question for?
Maureen.
Yes, I'm listening.
She mentioned some challenges, amongst which there was limited.
There's some noise at the background, like a fan or something.
Pardon, can you hear me?
Yeah,
Yes.
with some background noise.
There's some noise.
I don't have any noise here with me, but I can also hear a lot of background
noise. Yes, yes.
Okay. Okay. So I wondered what your proposal would be. You talked about limited health services in the rural. How do we close the inequity gap? Because remember that one of the SDGs is talking about universal coverage and is talking about inequities and equalities. So how do we close this inequity gap, which you identified? And the issue of vaccine hesitance that was raised by Dr. Lillian, can she explain how we can overcome the issue of this vaccine hesitance? Thank you.
So Maureen, please go ahead. Let me get Dr. Lillian.
Thank you, Prof, for the question. You know, the issue of inequality and the healthcare gap in rural environments is a big problem in our country. In my presentation, I mentioned the dichotomy in Nigeria, the urban and the rural area. But we as M1 can come in and do something. First, we have to interact with the government people, the policy makers. There must be a higher pay or higher remuneration for doctors that will make them to move into the rural environment. Lots of things are happening there. It's also home to many of our maternal mortality. We cannot do it alone without getting the government in, because we need the government to strengthen our primary health care. It is the basis of everything we are doing. But what we normally have is mostly taking care of the few primary health care within the city. But when you go to the rural environment where it's needed, it will almost be in a comatose state. Having a building with a big signboard of primary health care is not the same thing as having a well-equipped with primary health care with qualified medical personnel. So we need to start with the government. And one must interact with the government. We need to do also studies that we bring into more visibility, making all these deficiencies to be visible. We need to meet them in government as M1 and cry up to them to strengthen our primary health care. We remember the 6 claims of World Health Organization. They are not so big. It's just for government to put people there that we educate them. And also, as I mentioned, we need outreaches. Even we in town, we notice that anytime we're carrying our outreaches, we tend to concentrate to where we can easily reach people we know we can interact. But all those areas, in one of various states, while doing outreaches, we look towards those areas with no light, no electricity, we can offer to work there, even if it's an hour in a week. And we rotate it among ourselves. If we must think of elimination of tetanus, both maternal or neonatal tetanus, we must be ready to sacrifice. We must be ready to get the government to come in. We must strengthen our primary health care. We medical women, we also offer ourselves personally to move into the villages. Thank you.
Thank you.
Hello, Dr. Agbonle, I'm back in. Hello?
Hello?
Yeah, I'm asking, Doctor. Was I asked the question? Sorry, my network.
I can't hear a thing.
Hello? Hello?
Network must be bad. I can't hear.
That's the question. She said M1 should be willing to go to the rural areas for our outreach so that we can increase the awareness on all these conditions.
Yeah.
That was what Dr. Morin said. Dr. Agbonle, are you there?
Somebody else was in the
And
background.
also government involvement and strengthening our primary health care.
Yes, I'm here, ma. Sorry, I was muted. I know Prof had a question for Dr. Lillian. So something about hesitancy of taking the vaccination.
Hesitancy and missed opportunities. How do we address, Dr. Lillian?
Dr. Lillian, are you hearing that question?
Yes, I heard her. Can you hear me, please?
Good. Oh.
Can you hear me?
Yes, but you speak up a little louder. Speak up a little louder.
Okay, can you hear me now?
Hello?
Yes, but it's low.
Oh, what about now? I'm actually shouting. Can you hear me?
Don't speak loud.
Okay.
Shout. Shout.
Okay.
And put your mouth close to the phone or the device.
That's what I'm doing. Yes, that's what I'm doing. Can you hear me now? Is it better?
Okay. Yes, we can. Yes, we can.
All right. Thank you very much. Okay, so concerning vaccine hesitancy is one of the issues, that has impeded the uptake of tetanus uptake. And it's usually because of, fears about the safety of the vaccine. Because, and these are things that are fired up by rumors that, the vaccine, contains certain things that might, make the children sterile so that when they cannot have children, or that, they want to harm them. The whites are trying to depopulate, black nations and things like that. We are all familiar with all these rumors and things like that. And that's why the issue of, having community outreaches, health talks, and then encouraging health traditional rulers to come along in this drive, because we cannot do it alone. The community must own these programs. So if we are able to get the community interested, and they take responsibility for their own health, we make them see the importance of the tetanus vaccine, immunization, and what it does, and be able to show them, countries that had this problem like us, and then now they are free, like in the Western world, it's almost non-existent. And what did they do? They took vaccines. Their vaccine coverage is very high, and above all, they implemented these simple hygienic measures that we have been talking about: hand washing, good cord care, and some of these things are attached to traditional beliefs. Some people believe that they must use certain herbs for cord care, so we have to now explain. So the traditional rulers have to be there, with us. We have to carry them along, so that when they hear it from the mouth, when the people hear it from the mouth of their traditional rulers, they will receive it or accept it better than if they hear it from strangers. So in everything that we are doing, whatever programs we are implementing, we must carry the traditional rulers along, and so with the religious leaders as well. So if we know those people that are opinion, leaders, and we, incorporate them in our fight against this scourge, we will surely. And aside that, like media enlightenment, like I mentioned in Sierra Leone, and in other countries like Pakistan and the rest, they discovered that, with a good media exposure on tetanus, telling people about what tetanus is in simple language. Like in Nigeria, we know that a lot of us understand Pidgin English, and so many people have radios, even when they do not have television. Some people read papers written in their languages. So we can explore all of these avenues to address the issue of vaccine hesitancy, explaining in simple terms what tetanus is, what the vaccine is all about, and the issues of the hygienic method, because one cannot stand on its own. They all have to go together. And after that, then we talk about now getting the feedback on what we have implemented to see the response, of the community.
Okay.
These measures that we put in place. So I think address that. We cannot do it on our own, no matter the grammar we speak or the kind of things we do. There have been communities where primary health care centers were built, and yet people were not going to access care there. And that's because they were not made to take ownership of those centers. They did not see it as their own project. The government just went there and just did it. Maybe they didn't even ask them, just built it there and didn't even care about what their needs were. But the moment we discover that, okay, this community or vaccine hesitancy is worse in this a part of the country or in this community, then we will now put in these measures to address them. And at the end of the day, we're able to get a feedback by how much access they seek to getting these vaccines, and then how it will subsequently turn out in terms of these indicators you mentioned. That is the neonatal tetanus elimination index, which is the less than 1,000 live births, and then the same thing for the maternal tetanus. So I think we can address it this way. We do it at the national level, state level, local government, and to the world level. And then we now follow it up with these other measures that will help us at the traditional leaders, the media, the religious leaders, and then get the parents and the community interested in what we are doing. And they will be the ones now driving it. They will be the ones by word of mouth, spreading the goodness of the benefits of this vaccination. And then we'll not have to struggle to get this disease eliminated in Nigeria. I don't know if I've been able to address the question.
Thank you, Dr. Lillian. Somebody else still has a question for you.
All right, ma'am.
Dr. Oki, Irene Oki. Okay, please ask. We don't have much time now. All right.
All right. Thank you very much, ma'am, for your presentation. I would want you to address the situation whereby a woman had 3 doses of the tetanus injection in her first pregnancy. Now she's pregnant again after 2 years, and she's been asked to start all over again. She's able to take 2 doses, and then in the 3rd pregnancy, she comes back after 2 years, and she's been asked again to start all over again. So I don't, is that what is to be done, or is she supposed to just get a booster dose? And is that also under the scheme for them? Then secondly, if I have a 2 years, 5-year-old child who presented in the emergency with a laceration, am I supposed to vaccinate that child, write a TT dose for the child, or to give a booster dose, please?
Okay, okay. Thank you very much for the question. To the first question about the mothers, I don't, that procedure is not correct, or that schedule, or the way you have described it is not the correct way to go, because there's a schedule for a mother who has had childhood immunizations. So if she has had her 3 doses in infancy, it means that, you know, the 4th one will be given to her. She will now have to take 2 more doses, and that will be at 4 weekly intervals. So, and then the last one will come a year after. So that is why the health workers have to be trained. You know, it's one of the things we said must be in place. You know, one of the things we must put in place before we start expecting to get results. So health workers have to be trained on this schedule, that if a mother has had her childhood vaccine, 3 doses, you know, at infancy, then the next thing to do is to give her 2 doses of 2 booster doses, and they will come, you know, within 4 weeks interval, and then you wait until a year later. So if a mother comes, that's the essence of having the vaccination card, and the vaccination card will be left with the mother. And if she has been using the same facility, it means there should be a register in that same facility if that's where she's been using, and the register should have those dates or documentation of the vaccine she has had. So the health worker will now use the card to be able to, you know, address next, to know what next she's supposed to do. So if she's not due for the next dose, simply to say, no, madam, you've not, you are not due for the next one. Not that every time she comes in pregnancy, she must begin all over again. Okay, so it depends on the number of vaccines she has had. And if she has not had any at all, or she cannot remember if she was ever vaccinated for tetanus, then you now start, you know, with the first one at that first contact. Then 4 weeks after that, you give her the second dose. And then after 6 months, you give her the 3rd dose. So if she's still pregnant at that time, she can get all these 3 vaccines. But if she's not, if she just gets the first and second, and then she delivers, no problem. So after 6 months, she should come back, you know, to take the 3rd dose. And if she comes back in the next pregnancy, she didn't come after 6 months, she will now take the 3rd dose. She doesn't have to start all over again. And then after the 3rd dose, the 4th one is given a year later. The 5th one also is given a year after the 4th. So that's how it's supposed to be. And like we said, the first dose of the vaccine, of the booster, does not confer any protection. It is the second, from the 2nd to the 5th and 6th, that gives, you know, protection. So the first one, 2 years, the second one, 5 years protection, the 4th one, 10 years, the 5th can be as high as long as 20 years, and the 6th one, in fact, you know, can be more than 30 years. So that is how. So if you have you told me of a child who is 5 years old and had a cut, the management is, you know, according.
No, 2 years, 5 months.
Oh, sorry, 2 years and 5 months. Okay, so a 2 years and 5 month old child, as it depends on whether he has had the vaccines in infancy or not. So if the child has not had any vaccine in infancy, it means that that child, you know, has had this opportunity and has to start this vaccine schedule. So, but for that immediate period, the wound, you have to give the child tetanus injection, because he has never had, if he has never had any, it means it's not protected. So the child has to take the TT or the TD vaccine. So you give that to the child, and then you start. So after 4 weeks, the child comes back again, you know, then the 3rd one after 6 months, the 4th one. So like that. So you now follow the schedule for giving the dose. So that's how it's supposed to be. So the child should take the vaccines, but to follow the schedule, and then you treat the wound accordingly. So you make sure the wound is cleaned, and if there's any need for debriding, should be done. Make sure that the child is vaccinated with tetanus vaccine, and then give other treatments as appropriate, you know, when the child gets to the health facility.
Ma'am, sorry, I'm asking for a child that is already vaccinated. She had 6 weeks, 14 weeks.
Get a booster dose.
Okay. Thank you, ma'am.
If you think that that wound is prone to tetanus, give a booster. Or if you think it's a clean one, that the object that caught the child is not rusty or wasn't dirty or anything, and it was not a deep wound, then you might, you know, decide to leave out the tetanus injection. Otherwise, if it's from what we have mentioned, all these sharps that are and then deep, and the place where it occurred, and you think it's a tetanus-prone wound, then the child should get a booster dose.
Thank you, ma'am.
Okay. That's okay. Are you okay with that answer?
Yes, ma'am. Thank you so much.
You've asked a question that a lot of us see. We see children and we know that they've taken their immunizations as babies and they appear before 5 years and they're supposed to take but like she said, if you look at somebody has a very noisy background. Okay. If you look at the object, if you're able to, in fact, I look at it that every object is dirty.
All right.
I may be wrong. I may be wrong, but I would prefer to give that child and make sure that the child is alive, not come back with tetanus. I don't know, we're all, we have experts here that have told us something. So I think I will just go with what you said.
Yeah.
If
Dr.
you suspect the object,
yes. Just protect the child immediately.
Yes, protect that child.
Yes, because we only add to the child's immunity. Only help to boost the child's immunity.
Yes. Okay. Thank you very much. I think that's the only other. Any other questions? Oh dear. Yes. Any other questions? If there are none, we're going to go on to the next two lecturers, and I believe that they are ready. Yes, I have Dr. Chima. Yes, she's ready. Okay, and I'm going to introduce her to us, and then she will present. Dr. Osarity Uche Chima is a pediatrician whose interest is in neonatology and community pediatrics. She is presently a consultant special grade 2 at the Federal Medical Center, Asaba, where she has worked for about 12 years. Uche is married to Tony, and they have 3 lovely boys who she's very passionate about. She had an undergraduate training in University of Benin College of Medicine and postgraduate in University of Benin Teaching Hospital. She's a fellow of the West African College of Physicians. She's a member of the European Pediatric Infectious Disease, European Perinatal and Neonatal Society, European Respiratory Society, member of the Pan-African Thoracic Society, member of the Nigerian Society of Neonatal Medicine, member of the Pediatric Society of Nigeria. She had automatic appointment for housemanship as one of the first best 10 graduating students. She had a federal government scholarship award during her secondary school, which she had at Federal Government Girls College, Benin City. She has been an honorary lecturer stroke consultant at the Gambia University College of Medicine and Royal Victoria Teaching Hospital. She has worked at the Medical Research Council Laboratories as a research clinician. She has been involved in a lot of studies in children, especially in the area of severe pneumonias in under 5s. She reviews articles for some journals. She is a neonatal trainer for Essential Newborn course. She is involved in training of health workers in some communities. She was one time head of Department of Pediatrics, Federal Medical Center, Asaba. She's passionate about excellence and does all within her ability wherever she has the opportunity. She has served in different communities, both medical and Christian. She got an award for the International Women's for her enormous contribution to the lives of women. She enjoys traveling, loving, and caring for people and cooking. I think I've enjoyed the loving and caring part of it. So we welcome Dr. Osarity Uche Chima to give her topic on the clinical presentation and management of neonatal tetanus cases. You're welcome.
Thank you very much. Good afternoon. Good afternoon, Madam President and
all senior colleagues present, and my teacher, Professor Angela Okolo, who just finished her presentation, and all presenters. They've done very well. Everybody has done well, but someone has made my job so easy, and that is Dr. Mori. Sorry, I will learn how to pronounce your name after the presentation. So just allow me to go with Dr. Mori right now. So she actually did the presentation for me. So we are going on straight to, Dr. Bobola has announced the title of the presentation, and my outline is as follows. But I'm going to skip some. As I earlier said, Dr. Maureen has done justice to it. And if I'm going to start talking about it, it might be boring, in as much as repetition is not deep and lasting impression, but I would not need, she did read justice to it. So this is my outline. Epidemiology, I'm skipping that. Risk factors, pathophysiology, complaints, history, clinical features, management, prevention, and some key facts with my abstract. The two that I would not be spending much time in would be epidemiology and pathophysiology, because Maureen did great justice to it.
Thank you.
Yeah.
Thank you.
Yeah. So in the midst of introduction, which has been done basically by everyone, neonatal tetanus is a non-communicable vaccine preventable disease, and is caused by the gram-positive anaerobic bacterium, Clostridium tetani. It occurs in newborn. When we talk about neonates, we are talking about the first 8 days of life. And it's actually a public health problem in many developing countries, and a major cause of mortality and morbidity in some countries, including our own, with the challenge we had recently in the northern part of Nigeria. Neonatal tetanus is caused by the effect of a neurotoxin produced by this anaerobic bacterium, Clostridium tetani. It results from unclean delivery and unhygienic management of umbilical cord in an infant born to a mother who has not been immunized against tetanus. Professor Kolo has done justice to the unclean environment and unhygienic management of umbilical cord. And Dr. Lillian also did justice to immunization. Neonatal tetanus is a neonatal emergency requiring hospitalization, and this will usually last up to 3 weeks to 5 weeks. Once contracted, neonatal tetanus, I've said I'm not doing much about the epidemiology. So we all know the cause. There is an obligatory anaerobic organism, which is found everywhere in the world. Even the developed worlds that have overcome it, they still have it in their soil and human feces. But their hygiene have put them on top of us. So, and the spores can survive autoclaving of 121 degrees Celsius for 10 to 15 minutes and are relatively resistant to most chemicals that will kill organisms. And germination of the spores is not exposed to sunlight. Yes. So if case fertility rates was still ranging between 35 to 60%. We wonder how many people survived, how many of the babies survived in this last report of neonatal tetanus. The ratio of male to female ratio the male to female ratio worldwide is between
Dr. Chima, are you with us?
I think his network.
His network, because she's still here, but I can't hear her.
Let's give her a few seconds.
Yes.
Lost her.
It's like we have.
Hello?
I'm trying. Okay.
Hello, share my slide
okay.
again.
All right.
Are we together?
We can hear you, ma'am.
Hello?
Yes,
Go ahead,
we can
hear
hear you.
you.
We can hear you. Let me call her. We can hear you. Hello, Dr. Chima, we can see you. Oh, you're off again. Okay, she's the one calling me. Hello.
Oh.
I think we will. I'm looking at going ahead to the next. But Dr. Chima, I'm seeing you again. Can you present? We can see you. I've been calling you, but
Okay.
But you're not picking.
I can start mine.
I think yes, that's what I think we should do, ma. Then whenever we're able to get her, then we come back to her.
Share my screen. Please, can you enable me to share my screen?
Why didn't see? I don't know.
You're already co-host. Okay.
Okay.
All right. Okay.
I'm using.
Okay. All right, ma. Okay.
Right. So I need that one to be made co-host as well.
Okay. All right. I've done that. You've been made co-host, ma.
All right.
So, Good afternoon, everyone. We will take our national president, Dr. Mnte Oseji, and hopefully by the time she's finished, Dr. Chima would have sorted out her slide, her internet services network. So let's go on to the supposedly last lecture. So I'm going to introduce my madam. She is our madam. She's done so much, you know.
Endlessly.
In fact, she has brought out so much in us. So please, let me try and introduce her. It's very brief, but I wish she would be more. She's done quite a lot. So citation for Dr. Mnte Oseji. Dr. Mnte Oseji is currently the national president of the Medical Women's Association of Nigeria, M1. The permanent secretary there, Delta State Ministry of Health, Asaba, as well as the executive director of Public Health Impact Research Center, a research-based NGO she founded in 2002. She's a fellow of the National Postgraduate Medical College of Nigeria in Public Health since 2001, fellow of the Royal Society of Tropical Medicine and Hygiene since 2002, and a fellow of the West African College of Physicians, Community Health since 2003. Her research interests include COVID-19, maternal and child health, cancer, HIV/AIDS, gender-based violence, health systems management, and women and youth empowerment. Her research and consultancy experiences include principal investigator for the UNFPA Fifth Country Program for Nigeria, baseline survey, health expert stroke resource person for National Maritime Administration and Safety Agency, NAMASA, NAMASA-sponsored program on HIV/AIDS awareness, advocacy, care and support, and reduction of stigmatization and discrimination against people living with HIV/AIDS in Delta State. Delta State coordinator for the demonstration community linkage project for the reduction of maternal and neonatal mortality in Okwanala community, sponsored by West African Health Organization and Delta State Ministry of Health, supervisor for the Health Facility Survey for Integrated Management of Childhood Illnesses, sponsored by the Federal Ministry of Health, Abuja, and World Health Organization. Ma, you are welcome. She's going to take the role of social mobilization in implementing successful immunization programs.
Thank you very much.
Over to you.
All right. The topic has been introduced, and I would like to, before I go to the outline, refer to Professor Kolo's charge to M1. She said, M1 should facilitate improved access to CBKs. I believe that's community-based kits. Please kindly correct me if I'm wrong. Supervise, document, and monitor implementation of these activities. Continue to increase community awareness on the importance of assuring hygienic delivery and cord care in hospital and non-hospital settings, and continuous implementation of infection prevention and control mechanisms for maternal neonatal tetanus elimination. Increasing immunization uptake and coverage for maternal tetanus toxoid at antenatal care and possible supplementary immunization activities towards the attainment of MNTE in Nigeria. So we are going to take this to heart, and we are going to, in the course of today's presentation, see M1's efforts at maternal neonatal tetanus elimination. But there is no doubt that these efforts cannot end with this biennium 2019 to 2021. We have been able to create a lot of advocacy and awareness creation and even partnerships, but 2 years is not enough to complete the assignment. So it is very important, and we thank God for the continuity system entrenched by our founding mothers. And the charge is now for the national president-elect to look at this project critically with a view to continue to implement the activities that we have done on MNNTE, because we do not believe we can be certified as free of MNNTE in the year 2021. Thank you very much. So my outline is as follows. I'm going to try to be very fast because I know that we still have another presentation. And I will talk about health education, which is one of the aspects of social mobilization for health. It's defined as a combination of planned learned activities that enable people voluntarily to behave in ways that will promote health, prevent illness and disease, and recover from illness. So when we see that people are not exhibiting the behavior we want to ensure that they have good health, we have to look at whether we've done the health education right. Now, an example of health education by M1 Delta State branch was carrying out a breast cancer awareness program several years ago, but they had to do a baseline study first to determine how much people knew about it. And they discovered that 53% of women knew somebody that had breast cancer. It appears that many of them did not know how they could prevent it or what they should do to detect it early. And 70% of the women that had breast cancer were confirmed dead. So they know that it is a fatal illness if not caught early and treated. Now, for health education, there are personal methods like interviews, group discussions, songs, meetings, town criers, folk tales. They are all means of carrying out health education. In these personal methods, the opportunity for feedback is available from the audience. But how many people can you meet in a meeting? That is the challenge with personal methods. But you also have the impersonal methods, such as messages conveyed by the print and electronic mass media. This could be through jingles, stories, articles, dramas, films, and so on. And they have the advantage of reaching large numbers of people, and the messages can be repeated over and over again. And if you use local sources, the communities, the messages carry more weight. The only problem is that some messages may be understood. I once told a colleague that the COVID-19 protocols that were instituted by NCDC to enable us to reduce the spread, curb the spread, if we had asked the native doctors to promote it, would they have done a better job than we, the orthodox medical practitioners, particularly in the rural areas? Because a lot of people believe that it is a scam, maybe because it is the orthodox medical practitioners that are promoting these protocols. So we always have to look at, if people are not responding, obviously there's something wrong with the way we are either sending the message or the way they are receiving the message. Then another part of social mobilization for health is advocacy and lobbying for health, which is what M1 is doing. Advocacy is an organized approach to promoting an issue and motivating others to take action. And it's aimed at making change. Our advocacy for MNNT is to give it a high priority. It is neglected. It is neglected in favor of polio eradication, which, thank God, is out. Now we have COVID-19. Before anybody will remember, then we have the other routine immunization programs and so on, vaccine preventable diseases. But if we shout loud enough and we are very convincing, we will be able to get the powers that be to give it the top priority and do the needful. So advocacy can be about providing a health service. And in this case, we want maternal neonatal tetanus elimination activities to be provided. You have to develop key messages. What is the issue? What is the solution? We have an issue. We want Nigeria to be removed from the list of 12. What is the solution? Professor Kolo and the other presenters have given us the solution. What is the action? M1 will do her own. But you know that there's a limit to what M1 can do, because M1, every administration is just there for 2 years and our resources are limited. But we can advocate to those who have the resources. And what will be the benefit? So all these are the messages we are going to pass across to get the stakeholders to understand why it is a problem and what needs to be done. Then we will determine our approaches and tactics, implement the advocacy intervention, carry out research, monitoring, and evaluation. And we have two types: the process evaluation that looks at indicators as to how many health workers are trained, or how much equipment or drugs or vaccines are supplied, and outcome, where you have number of deaths. It could be deaths from neonatal tetanus, it could be deaths from other things. And then you now go for your meeting.
Hello.
And in your meeting, you in your meeting, please, can you admit these people? They are disturbing my screen. In your meeting, you look at your key points, you have your spokesperson, stay focused, and at the end of it, you meet as a group and you follow up. The problem is many of us do one advocacy meeting and we do not follow up. For most advocacy activities, we expect you to budget for at least 2 advocacy meetings. And when you are sending your letters requesting for advocacy, be ready to send reminders up to 4 times until you are given audience. Now, another very important aspect in social mobilization is using the school health program. We have school health program at primary, secondary, and tertiary levels. But for several years, M1 has been focusing on primary and secondary. This school health program denotes all aspects of the school health program, the school program that contributes to understanding, maintaining, and improving the health of the school population, consisting of the school children and the school personnel. So if you want to create awareness on something that you want all families to imbibe, one of the best ways is going to the school children. I do recall when we started our school health program in 2009, yes, in Delta State. And when I talk about immunization at the assemblies of these schools, I show them my own child's immunization card. And I tell them that my child has completed the immunization several years ago, and the last one was measles and yellow fever at 9 months. And then I ask the children to go back and ask their mothers to show them their own immunization card and indicate whether they too also completed their immunization. I was very surprised when 2 of my friends called me to say this was what their children asked them to do because I went to their schools. Can you imagine that level of impact? It did not cost anything. It just cost us to wake up early, enter our vehicles, which we would have entered anyway on our way to work, and go to the school in time for the assembly and just talk to them for about 15 minutes. That is what it can take to change the behavior of families with regards to immunization. So the components of the school health program, you have the school health services, the school health instruction, healthful school environment, and school-home community relationship. So these are some examples of school health programs that we have had in the past. This is our community health, chief community health worker in the Ministry of Health, creating awareness on hand washing. So with some other team members. These are opportunities that we are not using. Now we have community health workers in the communities, in the PHCs, and many of them just sit in the health facility Monday to Friday from the beginning of the month to the end of the month, and they do not visit any school. We have told the National Primary Health Care Development Agency to reactivate this program and use the community health workers. Because if you use any other group, many of them will claim that it is not their job description. Then we have to develop the appropriate IEC materials. The key words for IEC materials are information, education, and communication. You have to look at the source of the information, S, what is the message, M, the channel, is it a paper, poster, brochures, is it electronic, TV, and is it gifts to take away like biros, t-shirts, all these are channels. C, who are the receivers, caregivers, government, NGOs, that's R, and then what is the expected behavior, the effects, that's E. So you need to look at the relevant stakeholders, the message, make sure the text is legible. What would the visuals be? Would they be attractive? Would they enhance or clarify important points? What would be the approach? Does the visual convey fear, anxiety? Is it culturally appropriate? And then evaluate. I do not know if anybody evaluated the impact of the behavior change communication activities for COVID-19, because we saw several gatherings that were being organized, even sometimes gatherings of health professionals, and COVID-19 protocols were not being carried out. So obviously, if we have evaluated, we would have known that there was a gap. Then we will go back and reorganize and redesign our social mobilization activities. You pre-test your IEC materials, you disseminate and monitor, and these are some of the ways you can assess the IEC materials. So I'll quickly go through immunization team composition. If one is planning for an immunization campaign, what are the roles and responsibilities? These are the members of the state team. They could differ depending on what you have at any particular state. And the responsibilities include coordination of activities, advocacy visits to the highest authority. So when you are carrying out the campaign, you visit stakeholders in education, because you may have to go to schools, stakeholders, the governor's wife, the governor, the various people that you want to help you create awareness, the local governments. So you review the epidemiological data, organize, conduct, monitor state, LGA, ward level, and even facility training and micro-planning, review the materials, receive and store vaccines and other supplies, mobilize the task force on immunization, mobilize high-level traditional and religious institutions. Now, most times, UNICEF provides funding for social mobilization, and letters are sent to churches. So one way you can determine if really these things are working as they should is whether you're in your own church, the Sunday before the campaign, whether a letter was read out. I have received in my church several times the announcement that immunization officers from the local government will be coming to the area to do the immunization program. Make sure the finance is there, monitor and supervise, ensure operation room is functioning, ensure calling data is analyzed and submitted. The local government team, you have the state technical facilitator, you also have the local government team, their roles and responsibilities. The ward focal person. Nigeria has about 10,000 wards, actually 9,000 and something wards. Each of them is expected to have a ward focal person. So there is no reason why any place should be left behind if we are all doing our job. The ward focal person will support the traditional leader and the ward councillor to conduct ward level stakeholders meeting to discuss whatever the campaign is, to provide correct information to community leaders, to conduct community mobilization, and ensure that there is a ward map showing the catchment area. Then there will be daily review meetings, and hard to reach areas are outlined, and plans to get to those hard to reach areas are all done. So all these are the activities the ward vocal person is supposed to carry out. Then you have the vaccination team, and then the vaccination supervisor, the one that will supervise the various posts, and then the vaccinators. All these are supposed to be trained. You have the recorder. The recorder may not be a health worker, but will be helping to keep records. Then you also have crowd controller if you're going to have a large crowd in any place, to form and manage waiting lines. We have town announcers like the town criers. They help to inform the community on what disease is being prevented. So if you hear a rumor of people giving injections, sometimes we used to hear of people, oh, there are some people that came and gave injections to some children in a school. We don't know where they came from. That is why the social mobilization component is important, because by the time the people you know normally coming around, the town criers, the chiefs, and all the people in the communities have been talking about this one, you are already aware that this is a bona fide program that is government endorsed and being sponsored. So we'll quickly go to the reach every ward approach to routine immunization. Nigeria defined its reach every ward approach as a strategy aimed at the provision of regular, effective, quality, and sustainable routine immunization activities in every ward so as to improve immunization coverage. It has 5 components: planning and management of resources, reaching all eligible populations, linking services with communities, supportive supervision, monitoring and use of data for action. And one of the things is to have a planning meeting with the community leaders. It's the first step in the micro-planning process. It's aimed at developing or updating a catchment area map, having the updated, obtaining the updated master list of settlement, because we have a situation where people just migrate from places and come into other areas and they just form settlements. In our own area, we call them camps. So you need to be sure whether people are coming and forming settlements, and those people have to be covered, because if they are not covered, they can lead to outbreak. Remember what happened in 2016 when we thought we had cleared polio, and then suddenly some settlements that had never been reached suddenly came out and broke out and spoiled our record. So that's why you need the updated master list of settlements, and you've been using geographical information systems to get it obtained. Then if they're missing on new settlements, you identify them. So this is an example of a catchment map. It's usually in every primary health facility, and it shows all the important areas, the churches, the mosques, the markets, and so on. They are drawn, the major streets. So nothing is left. And this is done all over Nigeria. The question is, who is supervising to make sure that no nook or cranny is left? So we look at social mobilization activities for polio eradication, which we have successfully eradicated. This was the first round of the National Immunization Plus Days in 2015, just before the elections. And advocacy was done to our incumbent governor's campaign team, and they brought pluses in form of deworming tablets and salt. And you will be amazed, these pluses, the way they will change the behavior of the communities. People will queue up to be able to receive these gifts. So you can see the governor's picture is on it. Now, what happened was that when we did the advocacy and the opposition found out that the governor's campaign team was sharing salt, they too started sharing salt. We were not bothered. Our happiness is that salt is being shared and the people were all coming out to collect their salt and get immunized. So that is the kind of thing that advocacy in the right places can lead to. This is the second round of the National Immunization Plus Days. This was in Eka Northeast, and these are our partners for polio eradication, Rotary Club, and we're talking about the little push that remained to successfully remove polio from Nigeria. This is our First Lady during the flag off of the second round of the 2016 NIPD. So what we are saying is that polio is eradicated today. It took a lot of social mobilization activities to ensure that people were going to comply with the immunization and all that. So when we are talking about eliminating Mnte, let us begin to think of what it is going to take. Now, this is another immunization campaign, and this one is the measles elimination. It was the 2016 measles elimination, and the chief of staff was the one who flagged off on behalf of the governor. So these flagging off activities, they are all very, very important because they will ensure that the people know that this is a government-endorsed activity. Now here, we have the mothers at Idumujuno Comprehensive Health Centers watching video jingles, and some of the video jingles are on immunization. When they come for antenatal care, it was donated by our foundation in collaboration with a private hospital. So we wonder, when we have large waiting rooms with a lot of mothers waiting to immunize their children, why can't we put on the television and be playing jingles on immunization so that they will all be remembering all this? Because not all of them will have phones that are linked to WhatsApp. So this is another way we can create awareness. In all our large consulting rooms or large waiting rooms, we can have the television with a video playing jingles on immunization. This is the Director of Community and Director of Community Development and Social Mobilization in the Primary Healthcare Development Agency, addressing the Delta State Christian Association of Nigeria on some of these activities. Now, this is an interesting one. Our NGO, Public Health Impact Research Center, wanted to support immunization in Primary Health Center Idimogo in Annane North local government area. And when we asked them, what do they need for their cold chain? They said they have a fridge donated by an organization. They also have a cold box, and that one is available. They have a generator donated by another organization, but they did not have fuel. So you can see, when you want to support these activities, you must know what the people need. So what they needed was fuel. So we bought them fuel. You can see the jerrycan of fuel, and we're giving them 3,000 naira every month to continue to buy fuel so that they could get enough vaccines that will be kept in the fridge and cooled, and they will not have to ask the people to come again and again. But after about 8 months, we found out that because the measles coverage was what we're using to monitor. So every month they give us their measles coverage, and we found out that there was no change. It was then the community health worker revealed to us that they discovered that the women preferred to go and have their babies immunized at Iseluku, the local government headquarters of Annane North, because they will be able to ask their husbands for transport money to go to Iseluku rather than in Idimogo. I was shocked. And I said, this type of thing, you don't see it in the textbooks. You don't even see it in the journals. Unless you go there and mingle with the community, you will not be able to know. So the next thing we could have done before we left the project, rather the project, would have been to add clauses. Because in other places where we gave clauses, we found out that zero dose children are those that have never been immunized with anything, not even BCG. About 5 of them came out when they heard that Primary Healthcare Development Agency was giving plates and spoon to all the children that came for immunization in those LGAs that we found out were having a high number of missed children. The local immunization officer came to the meeting sponsored by WHO to say those gifts worked like magic. And she was shocked when in her own catchment area, 5 zero-doses children came out. These children would have been missed. But because of those clauses, they were able to come out and receive that. So sometimes I wonder, why do we spend so much money on training and meetings and so on? We should just give clauses to those children where the immunization coverage is so low and where the number of missed cases are so high. And that will create the social mobilization to make the behavior change that we are looking at. I'll round up with M1 efforts at Mnte. We started with a letter to the Primary Healthcare Development Agency, the National Primary Healthcare Development Agency, on the 14th of November 2019, requesting for partnership to implement this project. We were going to mobilize and send children from secondary schools to come and have themselves immunized in the health facilities across the nation, and they were supposed to ensure that vaccines were available and regularly provide data for us to know whether our efforts were yielding results. Now, we did not start getting the data until about 1 year later. So National did not meet up with their own responsibility on time. But meanwhile, we have started the Adopted Health Facility Project first in 8 states, and then we added another 5 states. And we gave them flyers like this, the MNNC flyer, for them to go and create awareness and encourage people to come for the immunization, particularly young children, young girls. Now, I used to wonder that in places where you do not have a lot of teenage pregnancy, of what benefits is it? But let them just be immunized, because you don't know where they will go. You can find out that from SS1 to SS3, they will all be immunized. So wherever they end up getting married to, if there is no antenatal, nothing, you don't worry about them. So let all the young girls be immunized. But the other issue is, from today's presentation by Dr. Murray, she said post-abortion neonatal tetanus. And that is another reason why we should immunize these young girls, so that those who may attempt abortion in substandard places and end up getting maternal tetanus from that aspect, or they may not even be successful with the abortion and they will end up having the baby, but they will have the baby in a place where they are hiding. So that is another opportunity for us to prevent that. And so finally, we started getting the data from the National Primary Healthcare Development Agency, and we have the TUT1 admin coverage from January to July 2020, and you can see it is quite low. The best was Yobe State, followed by Kaduna and another state. And then we had the TT2, it's also low, though I don't understand how TT2 is higher than TT1. Normally, you should have dropouts from TT2. So we need to verify this, but this is what they gave to us. And then they gave us the neonatal suspected cases by the states. And based on that, we found out that 12 states had validated cases from January to July 2020. We have Anambra 6, Bayelsa 5, Cross River 1, Delta 1, Enugu 1, Imo 1, Katsina 4, Kebbi 6, Kogi 1, Ondo 2, and Zamfara 5. So the question now is, these 12 states, M1 state presidents, M1 state representatives from these states, you have to go back and do something. I hope you are not expecting Madam National President to come to Katsina and come and do the advocacy. All this social mobilization, the M1 state president, you are being charged today to take it up and do something about it and give us reports at the next meeting. And so for our adopted health facilities, this is coordinated by the National Coordinator, Dr. Agbonle. You can see, this is Zamfara. They reported for 8 months and they had 1 maternal tetanus case and 12 neonatal tetanus case. And that was why we raised an alarm and we were able to inform the Federal Ministry of Health as well as National Primary Healthcare Development Agency that this is a problem. And we are already working to see how we can be part of the solution. Now, M1 cannot solve the whole of Nigeria's problem. We do not have the resources. Already we are working in the health sector, either in the private sector or in the government sector. So all these efforts we are doing under the auspices of M1 is extra time because there is no medical woman that is full-time employee of M1. Whatever we do is our volunteer time, our sacrifice time. But these pilots that we have started working with, if we are able to demonstrate the way we are monitoring and evaluating them, we are able to demonstrate a positive effect, a change in behavior, a reduction in cases, an increase in vaccination coverage, then we can sell the idea to those that have the money to scale up what we have done in the pilots. So in conclusion, in order to improve the health indices of African nations like Nigeria and achieve feats such as maternal neonatal tetanus elimination on the heels of polio eradication, we must institute regular supportive supervision that will involve social mobilization for health and health data management to strengthen the health system. Thank you very much for your time. And
thank you very much, ma'am. Thank you very much.
Thank you.
Like you said, yes.
Thank you, ma'am.
When Prof was talking, we had talked earlier, and I was worried because I knew that we're going to end our tenure, and someone else is going to take over. And you know, yes, you've done a lot, but the adopted health facilities, I don't know, it's only the next the next biennium that can determine do they want to continue or not. But we've played a strong part, and hopefully those adopted health facilities will show, you know, be able to cause a ripple effect in their different states and make sure that the the primary healthcare centers or whichever facility we have chosen, shows itself as having best practices done and others are able to follow. So let's see how it goes. But like you said, Ma, it's volunteer work. It's something that we'll see how it goes at the end of the tenure. Hopefully it will get better and better and stronger after that. So I'm going to invite Dr. Chima. I hope she's ready now to.
So the challenge.
I think what you do, Ma, is don't put on your, okay, can you put up this thing without putting on your video so that you just present?
I can do that.
Okay. Okay, yes. Let's do that so that you don't have too much on your
introduction.
Okay, all right, Ma. Okay, so wait, we'll continue with you, Ma. Yes, Ma.
Yes, thank you. No, sorry.
So this will be our last presentation. After this, we'll have questions again, and we will wrap up. So let's listen to Dr. Chima.
What's the problem?
Right. Just
Hello?
Hi.
Can we hear me?
Yes.
Okay, thank you.
Wait, no, wait. Yeah, Malu. Okay.
Madam, so you need money to get this done. Okay, I'm trying to see where I was. Okay, we were at the female-male incidence ratio. And I talked about that. Are we seeing the slides?
Yes, yes.
Yes, we can see the slide.
Okay. That the female incidence, an increase in the incidence might be as a result of the attention given to the male child in a home. And then the other thing would be because of possible female circumcision in some areas that have been attributed. Do I have two slides share? I can't control my slide from this way.
Just go ahead. Just go ahead. Sometimes it's very tricky.
Okay.
Dr. Chima, let me share for you from here. Is that okay?
All right. You can do that
you see
because
my...
I thought
Okay, I'm sharing now. So I think that's, is that okay?
It's okay. I usually prefer sharing my own slide. All right.
I know.
Epidemiology, still continue, just highlight.
Put off one of your speaker, put off one of your speakers. Put off one from one of your systems. You're using two systems, put off one speaker.
I had to do that because of
mute it so that won't have an echo. Otherwise we're having an echo.
But it's okay now, I think.
Okay.
So
all right, continue.
The tetanus is not directly transmitted from person to person. Infants born to immune mothers acquire temporary immunity for about 5 months. However, if a neonate is born less than 15 days after mother's second immunization, the baby would not acquire any immunity. So these are the risk factors which have basically been talked about by other presenters as unvaccinated pregnant women, unhygienic conditions during childbirth, animals and livestock kept near the vicinity of home. We know that the organism lives in those areas. Use of traditional methods for umbilical cord management, rat feces, ash, helps, even including cow feces. Unclean hands, which Prof talked about very well in our presentation. Newborn exposure to raw soil dust. Lack of awareness of symptoms. Access to primary health care and lack of access to primary health care. So that gives them the room to visit traditional birth attendants and seek all forms of care that can also lead to neonatal tetanus, and traditional practices like circumcision. The pathophysiology was also widely flogged. So we know that there are two toxins the tetanus-lytic activity. The one that has been recognized to have the pathological activity are neurotoxin. Tetanus plasmin is a neurotoxin and is responsible for the clinical manifestation that we see in tetanus. It spreads through tissue spaces into the lymphatics and vascular spaces. It enters the nervous system at a neuro resulting in disinhibition of motor neurons. Hello, I hope we can hear me. The
We can
tetanus.
hear you now.
Yes,
You
we
were
can.
lost for a while.
Okay.
We can. It's breaking, but it's okay.
It's okay. I don't know what is happening with the.
Yeah.
Okay, can we
Okay.
move on?
Yeah.
You are controlling the slide, Dr. Bobola.
Yes, we can move.
Yes, I am. I'm also.
Okay, can we move?
What is in
All right. Should I continue to move, or is it?
We said that.
All right.
Yeah, no, I'm okay. I'm okay here. This is the mechanism, a photographic display of how the tetanus plasmin moves to the neurons and cause inhibition of the neurons, which now results to excessive spasms of the muscles. So we can go on. Please, next slide. The complaints of tetanus and the history. In neonatal tetanus, symptoms are often preceded by the newborn inability to suck. That is usually the first symptom that they would present with. And the symptoms that also can be not specific because it's an infective process. It's not just the Clostridium tetani that might be present in the infective process. There might also be other organisms which will give the baby general sepsis, and baby can present with can start off with not specific symptoms. But the usual thing they present with is the inability to suck or excessive crying, which is as a result of the lockjaw or the rhizostomy sardonicus. Tetanus, please, can you help me get back there? Doc?
Sorry, I'm back.
Okay. No, I'm on clinical futures. I'm wondering what is happening.
Okay, ma'am.
Sorry for all this. It's my internet. I think because I should have gone to the office, doing it from home. Are we there?
Not yet. I can't.
Okay.
I think I have to get back to.
Okay, I'm there.
I have to.
I'm there. I think I could also control it from here. So there's usually a history of poor hygienic birth environment. We looked at the risk factors not too long ago, which include a poor hygienic birth environment or being attended to by traditional birth attendant, history of no tetanus toxoid vaccination taken by mother before or during pregnancy. And there's usually a history of poor cord care. Like the one we had last year, I was amazed. She was using cow dung and she had some other things. She used sand also, in as much as she said she put the sand on fire to heat it up. But that not contributed to the child even having burns on the skin. Then diagnosis of tetanus is entirely based on historical and clinical findings. Thus, accurate identification might be challenging for clinicians who may have never encountered a single case over the course of a career. Clinical tetanus starts showing symptoms. Tetanus starts showing symptoms in newborn at about about 3 days after birth. The incubation period is between 3 to 10 days. And the incubation period is there most times is at the age when the baby presents. The first sign of tetanus in a neonate is usually an inability to suck, which I've earlier said. And characteristic features of tetanus are trismus, lockjaw, or inability to open the mouth. And these are the things that will commonly describe, they are clinical terms: Rhizos sardonicus, first brie, and raised brow. I'll show you a picture of that. Opisthotonus posturing, back arching of the spine as a result of the spasms of the muscles of the back. Rigidity of muscles with generalized spasm, irritability, continuous crying. Those crying might be due to the fact that this baby has not eaten one's food, so there can be excessive crying at presentation. This is generally the scoring that is used to classify the severity of tetanus, but for the neonatal tetanus is basically a severe one. The only thing that could differentiate it, that could maybe reduce the severe, classify it as not so severe, is the age at onset. Those some present at 1 to 4 days, and those ones are usually very severe. And we can see the table which I have shown. Then the presence of temperature with some of them. Some of them could also have pneumonia, and then the frequency of spasms are all what is used for classification of the severity of tetanus. And a score of 15 usually is expected to recover. The scores below that, maybe 3 to 10, usually might not recover. These are pictorial features of neonatal tetanus. There, hello, I hope we are still together. Rhizos sardonicus, which is
hearing you.
Okay, thank you.
But we can't see the slides. We're not seeing the slides.
You are not seeing the slides?
Are we seeing anything, ma?
I'm seeing something.
Okay, I'm not seeing the slides.
Maybe you should share your slides, ma'am.
No slides.
Sorry? Are you not seeing the slides?
No, ma'am.
No, we are not seeing the slides.
Oh. Okay.
Not showing, but we are hearing you very well. Carry on.
But we
because
can
of
hear
network.
you, but we can't see the.
Yeah. Okay.
Okay, they are showing now.
I'm trying to.
We can see.
Are we seeing the slide now?
Yes.
We're seeing the slide. Rhizos sardonicus and opisthotonus.
All right. Thank you.
Thank
you. What happens is that when the moment the slide sharing starts at this end, I don't see what is happening.
Okay, I'm not seeing.
I cannot move it. I can't move the slide. But no problem. I think I know what to do.
Okay. Let me continue to share and see how it goes.
Okay, no problem. We will get there. Okay, are we there? So
you are sharing now. You are the one sharing, yes.
Yes, it's easier for me when you are diagnosis. Tetanus is often difficult to detect. So the diagnosis.
Okay.
I think your bandwidth is not
So
enough to support audio and video. So just present. Let NC share the slides.
Slide share, yes.
Okay, you can't hear me. Is that what you mean?
We can
hear you.
Okay.
We can hear you.
Okay. In case of neonates, it must be differentiated from metabolic disorders like hypocalcemia, meningitis, and seizures. I will just make a comment there. For patients who have seizures, the seizures will obviously abort, but for patients who have neonatal tetanus, even the noise, seizures cannot be triggered. The spasms can be triggered. I think that would be an easier way to put it. Noise, lights, they cannot trigger or spasm, but those are usually not triggers for seizures in the newborn. Investigations, they are not specific. So we would investigate the patient based on other things which we are thinking of. So we do the CBC, which is the full blood count, which can point to, it can show the infections by raised white cell counts and leukocyte counts. There could also be electrolyte and urea derangement. The random blood sugar also, sorry it is not there, would also be done. The blood culture, we said, even if it grows Clostridium tetani, it might not be so useful. And we know that our culture yield in our environment is poor. The other thing that we might need to do that blood culture might help us with, if there are other infections with the Clostridium management. The goal of treatment in patients with tetanus include initiating a supportive care. Supportive care is very crucial to the management of this patient. And then cleaning up the umbilical cord, if it has to be debridement, because some of them might end up with ophthalitis and all that, to eradicate spores and alter conditions for germination. Then that is the wound care of it, aspect of it. The pharmacological treatment, which includes stopping the production of toxins within the wound, neutralizing unbound toxins, controlling disease manifestation. Components of the one of them is to stop the production of toxins, and those are usually the anti-tetanus serum. And then that is the antibiotics, and then neutralizing the unbound toxin, which is the anti-tetanus serum, and controlling the disease manifestation, which are the antispasm drugs. Then managing complications. Complications could include things like hypoglycemia. So the patient will need to be corrected for hypoglycemia and will be managed based on complications that we see. Well, correct management of neonatal tetanus can reduce mortality in as much as mortality is very, very high. We know that one of the challenges we have is that we don't even have a ventilator. Some of these babies can end up with laryngospasms and can have a respiratory arrest if one cannot intervene immediately. In terms of the supportive care, tetanus can never be managed as an outpatient, so the patient must be admitted. And because of the risk of reflex spasms, a dark and quiet environment should be maintained, and cord care with chlorhexidine, which Prof has talked about, should be used. Unnecessary procedures and manipulations should be avoided, because even touching the patient can trigger off spasms. Prophylactic intubation could be considered seriously if a ventilator is available in that environment. We must establish an IV access for hydration and for IV parenteral antibiotics. And then gentle suctioning of secretions of the mouth and oropharynx should be accessible. In short, we must have a suction machine by the patient's cot, not the one that you need to suction and you are running to go and get a suction machine. Then one has to insert a nasogastric tube for feeding and administration of oral medication when necessary, and provide hydration, and for providing hydration and nutrition. And the feeds should be done in divided feeds. Breast milk, of course, is the best, every 3 hours over the 24 hours. And what happens, immunization of survivor is part of the supportive care when they survive and they are ready to go home. This is an example of a septic cord, even with some cellulitis around the base of the cord. So this type of cord will need proper cord care. The pharmacological therapy, which is one of the mainstay of management, include tetanus immunoglobulin for a neutralization of circulating unbound toxins. That is the only thing it can do. It cannot handle the ones that are already bound to the neurons. Those ones will have to gradually undergo their half-life and baby recovers if the baby is going to. And there should be elimination of toxin production. And this can be achieved by using antimicrobial agents and the muscle relaxants for the manifestation of the disease. The manifestation of the disease is the spasms. So the muscle relaxant is very important in managing them. So for neutralization, I know that it was earlier said that the human tetanus immunoglobulin in one of the presentations is used in developed countries, but that is not accessible to us yet. So we use our anti-tetanus serum, which has a dose of 1,500 international units. And for the elimination of production of the tetanospasmin, that is reduction of growth of the Clostridium tetani, the antimicrobial agents are used to decrease the number of vegetative forms in the wounds, which is the umbilical cord. Yeah. For years, the penicillin used for this purpose, but it is not the current drug of choice because penicillin has been found to be an antagonist of gamma aminobutyric acid, which is a neurotransmitter, an inhibitory neurotransmitter. And what happens is that in tetanus, we know that the inhibition is abolished. So if we now give something that will inhibit the GABA, then that means that we will have an exaggeration of the spasms. So it basically acts as the tetanus toxin too, the penicillin G. So now the metronidazole is used, metronidazole infusion is being used for babies. And this is how it is given. 0 to 7 days, if they present within that period, they should have 50 milligram per kg, day 1, then after 24 hours, 7.5 milligram per kg every 12 hours. And 8 days, that is the dosage, and 8 for the babies. Other antimicrobial agents that are currently being considered are clindamycin, erythromycin, and tetracycline. But sorry, tetracycline should not be here. It's actually for the older people. So I'm sorry it is there. But the role of these ones have not been fully established, but people have full data of the effect of these have not been published, but some people have had some personal reports on the benefit of clindamycin and vancomycin especially. Then for the control of the disease manifestation, which is the spasms, the muscle relaxants are used. Diazepam, the benzodiazepines have been the main muscle relaxant, which has been used, chlorpromazine and phenobarbital. In recent times, people have started using magnesium sulfate and baclofen. For diazepam, this is the dosage, but diazepam is best administered in their management with a syringe pump. There you can control the flow rate of the dose that you are given. And this is usually the dose that is being given when the patient is on diazepam. So it's best done when you have a syringe pump or an electric syringe. The other ones, which I earlier said, phenobarb and chlorpromazine, these are given but the muscle relaxant effect. Why in some they give phenobarb and chlorpromazine alongside with diazepam. Magnesium sulfate, which has been used and it's a muscle relaxant and also can control the tetanus spasm. It also has impact on severe autonomic
Good afternoon. Yes, I woke up very early. Eh?
to the serum.
Hello, Dr. Chima. Dr. Chima seems to have left again. Dr. Chima seems to have left us again. Yes, she is. She is.
I think she has come back.
Okay.
The network is very bad.
Network, yes. Sometimes it's like that. And she had two devices. I don't know what happened to the second one.
Yes, I'm back home again.
Oh, great. I'm
There
sure you're
is my
rounding
slide.
up.
Can we see of the echo? Need that just to forestall. Okay. So what the other drug that currently that is also currently being considered is, can we hear me? Is baclofen. Hello?
Yes.
We are hearing you.
We can hear you, ma.
I hear you.
All right, thank you. Baclofen is a GABA B receptor agonist. Unlike what we're seeing with penicillin, that is an antagonist, but this one is it's a GABA2 receptor agonist. So we expect that it will counteract the inhibition, which results from the tetanus plasmin. Oral baclofen is thought to have poor penetration across the blood-brain barrier and hence ineffective in tetanus. So what is being done by some group of people like Muller and colleagues is to give intrathecal baclofen, and they've had good results from it, a higher survival of patients when they used it. And the daily dose infused range from 500 to 2,000 microgram. As well. So we talked about managing the complications earlier on. There are some complications that would arise as a result of the disease, which is aspiration. This could be aspiration, pneumonia, and then it could be as a result of also
It seems there's a serious challenge with her. Dr. Chima, are you still with us? She's almost at the end of her presentation. Very close to the end, but presenting on her behalf might not be very wise.
Since we are going to get the slides, so
we can let
see
it.
what. So we need to wrap up.
Yes. She's here, but can't. We're just not seeing her. There is well, let's see if she's almost through, and very few slides left for her to share. Just before we started yesterday, I had asked some of our presenters to prepare pre and post tests, and I was able to get one. So I think we will just go through those quickly before we close. And I would like to ask a Muslim from amongst us to get ready to give a closing prayer just before I close. So please, yes. Okay.
We're wrapping up.
Hello?
Is that Dr. Chima? Dr. Chima?
We're wrapping up.
We're about to wrap up, ma. We can hear you.
Since we're going to get the slides, we will get the remaining few slides that were missed.
Hello?
Network okay. Today.
It's really bad. Yes. So let's quickly go through. Yes, I want to go through this now. I think we can see them. Good.
Hello?
We're on to questions and answers now. We're wrapping up.
Hello?
We're wrapping up, ma'am. Oh, it seems she can't hear us. And we can hear her clearly.
Hello?
Let me put a call through to her. So, Dr. Lillian. Dr. Lillian, are you there?
I'm here.
Okay. So let's quickly go through this quiz before we close. I hope we can all see the quiz. Hello?
Are we rounding up from me?
Yes, we're rounding up.
Yes, ma'am.
Because the network is so bad.
Okay,
it's so bad.
I was almost rounding up. I thought I could just do that quickly. Can I do that quickly?
Okay.
These are
Okay, ma'am. Okay, ma'am. Please do so.
Yes.
Maybe you wouldn't share the slide. Just
no sharing.
Without the slide, because that takes.
Okay.
Get the
We'll just
slide
talk from
later.
her end. Yes.
There are some key facts which are still to highlight. We've talked about them over and over, and that is tetanus is acquired through infected wounds, especially the umbilicus in the baby, umbilical cord, and then it can be prevented by immunization of the mother. And majority of reported cases are better associated among newborns of mothers who did not have sufficient vaccination. And in 2015, 34 newborns died from neonatal tetanus at 90% and a 96 reduction since 1988, largely due to scaled up immunization. So we can see that there can be improvement, but if we still had up to 34,000 newborn babies die from this, then we can imagine what it used to be. Then, so that is basically what I want to talk about, and my references are there, which you cannot see now. And I want to thank everybody for listening. I'm sorry for all the apneic and spasms because this was maybe because I had to present a clinical future. For spasms of the.
It shows that we have to be serious.
So thank you very much. And I want to
thank you,
the president for the choice of this topic. Thank you, ma'am. And thank you, Dr. Bobola.
You're welcome, ma'am. It shows that we have to be very serious about this.
We need to be serious.
So I'm quickly going to go. Yes. So let me share these questions. Dr. Lillian, you can read them out and let's get the answers together. Let's see how we go.
So number one, quickly, thank you everybody for your attention and your time. How many doses of tetanus vaccine is on the MPI schedule? A, 3, B, 5, and C, 6.
5.
So what's the answer?
5.
We can unmute ourselves, please, so that we answer.
5. We're doing chorus answers. 5.
It depends on if it is for the mother or the child. If it's the mother, it's 5. If it's for the child, it's 3. It's independent.
So for the child, it's 3, and yes, and even for mothers, you should give them 3 vaccines. So the total of the tetanus vaccine they will get will be total of 6 if they follow it correctly. But the one scheduled is 3 vaccines on the MPI table.
It's not me, praises for me. Yeah, I think for mother zone is 5.
5, no? 5. Yes, but for babies it's 3. I mean, for the infant it's 3.
Okay.
Yeah.
So next question.
Your target for the mother is 3 vaccines when she's pregnant. Only dependent will catch her early. She should get the 3 when she's pregnant, and then the other ones will boosters. Okay. 1 yearly. Yes.
Yes.
Then number 2.
We usually give 2 doses.
Yes.
Then, when does a year later or when she's pregnant, we call it booster dose.
Exactly. Those are
booster doses. Yes.
All right. So then number 2, how does
question 2?
Yes. How does a neonate get immunized against tetanus? A, tetanus vaccination at birth according to the MPI schedule. B, via transplacental antibodies from a mother with immunity against tetanus. And C, from antibodies received through breastfeeding.
B. Yeah, transplacental antibodies.
Yes, transplacental antibodies. Good. Number 3, what is the minimum number of doses of tetanus vaccine required to confer immunity in a pregnant woman? A, 6, B, 2, C, 3.
B, 2.
Very good. Is there only one person answering? Do we all agree?
Two, yeah.
We were looking.
Yes,
Two.
two is the minimum required to confer protection.
I'll not answer again.
So please do. So number 4.
Number 4.
Yes, how long does the immunity of the second dose of tetanus vaccine last? A, 1 year, 2, B, 10 years, and C, 3 years. 1 year.
1 year.
The second dose. The first dose does not have any immunity, doesn't protect.
No immunity.
But the second dose.
Sorry, 3 years. 3 years.
3 years. Good. I wish. Oh, let's give a round of applause.
Thank you.
Okay.
That's good.
Next question.
All right, so then, number 3. The maternal antibodies protect the newborn.
We have 10 questions.
For as long as A, 1 year. No, sorry. For as long as A, 3 months, B, 6 months, and D, 9 months. Maternal antibody protection in the newborn, how long does it last? Is it 3 months, 6 months, or 9 months? At the least.
6 months.
Who can try? No?
Which answers are we giving?
6 months.
I gave 3 months, 6 months, and 9 months.
6 months.
3 months.
6 months.
Okay. 3
Months.
Yeah,
6.
Some would say, yes, some would say maybe up to.
Some say 5.
Actually, 3 months minimum. Yes, some say 5,
Okay.
but actually the minimum is up to 5, but the minimum is 3. All right, then tetanus infection is number 6. Tetanus infection is milder in neonates compared to what's happening? It's gone off.
I'm back. All right.
So look at number 6 again. Tetanus infection is milder in neonates compared to maternal tetanus. A, true. B, false. C, depends on geographical location. A, true. Yes, very true. Rapid and can be almost 100% total. Number 7, maternal and newborn tetanus is still a public health problem in A, Southeast Asia and Africa, B, North America and Southeast Asia, C, Europe and North America.
A.
Southeast Asia and Africa. A, correct. Very good. All right, so then we go to number 8. The commonest port of entry of tetanus spores in the neonate is A, the eyes, B, the mouth, C, the unhealed umbilical cord.
The unhealed umbilical cord.
Unhealed umbilical cord.
Very good. Yes, we dare not forget that one. All right, number 9. 3 strategies for MNT, that's maternal neonatal tetanus elimination, are A, good environmental sanitation, clean drinking water, and good antenatal care. B, good tetanus vaccination coverage, hygienic delivery and cord care, and good intervention and surveillance strategies. Which of them, A or B?
That was B.
D.
Oh, somebody said A.
All of the above.
Well,
the quiz is good.
B should be the right answer.
B.
I think B for
B is the right answer.
B covers A.
The right answer.
B covers A. Very good, because
covers
drinking water will be part of the strategy.
Yes. It's part of hygienic delivery. Yes.
Yes. Okay. Number 10. The current national immunization coverage is A, 20%, B, 50%, C, 33%.
C.
A.
C.
33%.
20%.
A.
C.
C. 33%. There was some improvement at the last report. Yes, in 2019.
We didn't hear you.
It's C, 33% currently from the last report. Yes. All right. So thank you very much. Let me give each and every one of us a round. Let's clap for ourselves. I think we did very well.
Yes, we need to clap for ourselves.
Attention.
Yes.
And thank you for your patience in spite of all the network.
Thank you, Dr. Lillian.
Go out there and work towards eliminating maternal and newborn.
Thank you. Thank you.
Thank you so much. So we need someone to take closing prayers for us. Any of our Muslim sisters here? Dr. Halima, please, I'm seeing you type something, so just take the prayers. Dr. Halima, are you there? If she's not there, can someone else take closing prayers?
Dr. Yahaya, are you still around? Dr. Safia?
Safia.
Yes, Safia, hey, is she there?
Annene, baby.
Safia, take prayers for us now.
Take the prayers now. Closing prayers, please.
Before we pray, I want to congratulate my friend, Dr. Maureen, Professor Vivian, my teacher, Professor Angela, the other pediatrician, Dr. Mnte, and of course our national president for her wonderful intervention.
Thank you so much for a wonderful time, ladies. You have done so well.
Yeah.
Really, baby. My fellow pediatrician, you've done more. So, okay, let me switch on my video, right? I guess.
Yes.
Yes, ma'am. I'm coming. Are we ready?
Yes,
yes, we are ready. Yes, we are ready.
Okay, so let us pray. In the name of our God, the most beneficent and the most merciful, we'd like to thank you for successfully leading us to the end of this wonderful CME. Once again, very enlightening and very enriching. We thank you for how far we've been able to go throughout this whole biennium, all the giant strides we have made. And we pray you continue to guide us, continue giving us more innovations, and continue letting us as we grow from strength to strength. Amen.
Amen. Amen. Amen. Thank you. God bless you all.
Yeah.
Thank you. Well done, dear. Well done. Well done. Well done, Dr.
Many of us don't have videos on, so
thank you.
Well done.
Thank you, ma. Well done.
Thank you. In fact, thank you all of you. Evo, thank you so much for your intervention.
Thank you, ma.
Madam National President, thank you, ma.
Thank you. Thank you, ma.
Thank you. Have a great weekend.
Yes,
we meet again.
I'm trying to snap us photographs, so but I'm not seeing many faces. So I'm snapping names.
Prof, your baby, hello, ma. My teacher, Prof. Your baby, hello.
So this
Dr. Kaibat, how are you? Which text is that?
Is she not still in ABU? I think she's still in ABU. Avita Iba. I know you're somewhere in the north.
Okay.
Thank you, Madam National President.
Thank you, Prof. We are grateful, ma. Dr. Halima. Nyako, nice
Madam
to see
National
you.
President, good afternoon. Well done. Thank you.
Good afternoon, ma.
Good afternoon.
Well done, ma.
Good afternoon.
Yes, Maureen, I'm coming.
Prof,
We're there. I'm there.
See you after a long time, ma.
Yes, I got Prof. Yes.
Bye.
Good afternoon, ma.
Good afternoon, everyone.
Okay.
Bye.
Dr. Rosemary.
Good afternoon, Dr. Lillian. It's Awalari.
Good afternoon, Lily. Well done. Good afternoon,
I saw your video. I
Maureen.
haven't seen it in a long time. Good to
Yeah,
see
how are
you.
you?
Well done. Bye, everyone.
Bye.
Bye-bye.
Prof, thank you very much. Bye. Yes.
Thank you.
Thank you.
Yes.
Bye. Ishoma, well done.
Bye.
Well done, ma. Well done, ma.
Bye, Professor Kolo.
Yeah, bye.
baby is saying hi.
Oh, okay.
See, Prof is looking ever young.
Thank you, my teacher.
Ma.
Yes.
All right. Thank
All
you. I will
right.
see you later. Okay.
Yes. Dr. Chima, thank you, ma.
Yes, ma'am.
Yes, I've
All right, bye,
captured
everyone.
as many pictures as I can. Yes,
Did
bye.
you get my own, Dr. Bobola? Did you get my own?
I hope I'm
Yes,
inside.
yes. That's Dr. Lillian. Ma?
Dr. Yaya, Sebi, how now?
Yes, I got majority. Majority.
F1 president.
It was a great time, Madam National President and National Coordinator.
Yes.
We really had a good time.
Yes.
Thank you.
Thank you, ma.
Hold on,
Thank you, ma. Thank you for honoring us.
A wonderful time.
Being our teacher, and we're still looking up to you. Evergreen, Prof.
Yes. That's our teacher.
Yes. Yes.
Hold on.
Thank you.
Bye-bye, ma.
Bye, ma.
Bye, everybody.
Bye.
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 Love you.
Dr. Mosumala.
Yes. Yes, now I'm there.
I've seen your face now. I've seen
I
it.
just switched my video on. I was online all through. Yeah.
I know. Yes, I knew you were online all through. So
yes.
I've caught your face. All right.
Yes.
Okay.
I just switched my video on.
Yeah.
All right.
Okay.
Nice session.
All
Well
right.
done.
Good night.
All right. Bye.
Thank you, ma. Thank you.
Appreciate you. Bye.
Yeah.
Dr. Lillian, thank you for your questions. We enjoyed them.
Thank you.
Have you?
Yes.
So much. Thank you so much. God bless
All
you.
right.
Thanks for your
Amen.
patience. Bye-bye.
I'm waiting for all of you to go home one by one. So I'm standing at the door. As you are going, I'm just waving bye-bye. At the door of the house. All right.
Yeah, bye-bye.
Have a lovely week. Yes, sir. Safia, go to your house. God bless you. Bye. Ijoma, thank you.
Go home. All right. Don't worry, we'll go home. I'm waiting for you to go home,
Yes,
sir.
we will. We'll just with you on the WhatsApp now. I'll waiting for me to go home.
Okay, no worry. Let me first see some few people go home first before I go home.
Okay, all right. Evo, how are you?
My friends are still here.
Evo, we didn't see your face, so stay. You are free to stay.
No worry, I'm going now. Bye.
You are free to stay. Bye. Take care. Have a lovely week. Have a beautiful week.
Okay, madam. Thank you. Where's the how do I just a minute? I'll soon be out.
Tap your screen and you will see exit. Yep.
Yep. It's just not responding.
Good.
Bye. No.
Good. Okay. All right.
I'm still out. I tapped leave. Okay, let me do it again. No. Maybe just
leave. You may see another leave. You may see another leave. You may see a second leave. You may see a second one. Watch out.
Okay, fine. So let me do that.
Yes.
Okay. Bye. Okay.
Tayo. Hey, my big sister.